nutrient-rich surroundings, which are leading to obesity, metabolic syndromes, and cancers, of course. To understand the weight loss response which occurs, the energy expenditure which is affected by the weight loss, there is a set point theory where the body always tries to maintain equilibrium. It maintains a stable fat mass. So gut physiology will always oppose weight loss. To understand, we have to see when we start a diet and we lose a significant amount of body weight, your calorie burns slow down, and you are the amount of calories which are burned by an activity also reduces in comparison to what the same activity used to reduce your body weight in the initial period. And you are in constant state where you are thinking about food or eating small quantities of food. So your weight comes back to the normal set point, which was your original set point. To understand this graph, we see the baseline energy intake. As we reduce our energy intake, the energy expenditure also reduces. So the set point is always maintained in center as long as you have not altering your set point, your weight is not going to reduce. So once we start a calorie restricted diet, we lose approximately 2 kgs of body weight per month. But many studies have pointed that 92% of overweight patients will regain their weight in 3 years. 98% of morbidly obese people will regain their weight in 3 years. Exercise is not very different. Only 5.3% success rate in weight loss for men, and there is no significant weight loss in women. So the moral of the story is lack of willpower in such patients is a myth. It is not about willpower. Body will maintain its equilibrium, hence diet, exercise, behavioral therapy alone is not going to work. There are too many environmental related factors which will affect the failures. Obesity impairs the quality of life. Every 5-unit increase in BMI, the risk of death increases by 39%. And bariatric surgery is only treatment for a significant and sustained weight loss. As we see in this graph, over a period of time, the bariatric surgery is the only option where people have maintained their weight loss for a longer time, for years. These weight loss are due to calorie diet, lifestyle interventions, diet, exercise. In 5 to 10 years, people do regain their weight. So basic mechanism in bariatric surgery, which it works, is restriction of your diet plus malabsorption. But this doesn't explain everything, or the detailed explanation by how it works is by altering the set point, as we have seen in the previous graph. Once your post-operative energy intake reduces, the energy expenditure which was reducing also changes, and that changes the set point, and that is how you maintain your weight loss. The physiology on the gut-brain axis, once the surgery is done, your gut environment changes, which increases the bile salt concentration, increases hormones like glucagon, like peptides, neuropeptides. It reduces leptin that acts on the taste, reward, and emotional part of the brain, and thus it changes the environment. Gut microbiota is a very recent theory, and a lot of studies are being done on that, where once the bypass or sleeve is done, the gut microbiomes, the microbiological organisms which are present, those are changed, and these increase the fat loss, energy intake, your insulin sensitivity is increased, your glucose uptake is increased, these triglycerides, lipogenesis, gluconeogenesis, all these factors are affected, which maintains the weight loss. Just a brief understanding of what a bariatric and metabolic surgery is. First is sleeve. The basic is sleeve gastrectomy, and these are the just few points where sleeve is a very simple and short surgery. And these can be performed in patients with high risk medical conditions also as a first step. If the patients are severely obese, they may be used as a bridge from gastric bypass to a different procedures. The only disadvantage is it is an irreversible procedure where almost 2/3 of your stomach is removed, and it has less impact on metabolism as compared to bypass procedures. Roux-en-Y gastric bypass is one of the most commonest procedures which is performed worldwide. It is a very reliable and long-lasting weight loss. It affects the remissions of many obesity-related comorbidities like diabetes, blood pressure, and hypercholesterolemia. Disadvantages: it is very complex as compared to sleeve unbanding. There are going to be multiple minerals and vitamin deficiencies, and patient may require a supplement. Similar with the one anastomosis gastric bypass, it is simpler than Roux-en-Y, and it gives an excellent metabolic control of the obesity related issues. Only disadvantage is because of the malabsorption, patient will going to need nutritional supplement and proper follow-up. Few other procedures are, this is a biliopancreatic division with a duodenal switch. This is a sleeve single anastomosis, duodenal anastomosis, and this is a proximal jejunal bypass. Newer methods like endoscopic sleeve gastroplasty is one of the methods where the concept is similar to sleeve, but stomach is not removed and stomach is sutured. The portion of stomach is sutured and only a sleeve of stomach is left open. And balloon has always been there. This is a temporary method of weight loss where if a young girl wants to get married in say next 6 or 8 months, this is a very nice procedure for a temporary weight loss. So at Karuna Multi-Speciality Hospital, Bariatric AWR, we also have started our bariatric program, and we have recently operated this patient. She was operated on this Tuesday. Patient is discharged yesterday, and in these 5 days, patient has lost already 8 kgs of weight. Thank you. Thank you very much.
Thank you, sir, for a very lovely insight on obesity. Obesity is really an epidemic today. And in spite of everyone knowing about it and talking about it, still it's on a rise. So thank you so much, sir.
Thank you.
That's a very important thank you for being on time.
Thank you.
Thank you, Brijesh sir, for an informative lecture. I request chairpersons to felicitate our speaker, Dr. Brijesh Dubey sir. If anyone has any questions, they can write it in the chat box. We'll answer them afterwards. Moving to our next lecture, Mommy Makeover Bringing Back to Normal by speaker Dr. Rajesh Koradia sir. He is a senior obstetrician, gynecologist and infertility specialist, pioneer of IVF and endoscopy in Mirabhayandar region, medical director of Mirabhayandar Institute for Reproductive Assistance, Mira Hospital and IVF Center. He has vast experience and interest in the field of evidence-based infertility, teaching, and community IVF. Rajesh sir, please take over.
Good morning, friends. Till they set up the laptop for me, I really thank organizer for giving me opportunity, and all the friends who has come early in the morning to encourage and to listen and to enrich their experience and knowledge. The previous speaker has talked about the obesity and obesity management. Dr. Bridges Dubey is an excellent surgeon, I know, in this region. So I'm sure he will also agree that the obesity surgery can take care of the general obesity. It reduces the BMI, but it cannot take care of the focal deposition of the fat. So that we can offer something for that, where the fat is resistant to go. And with all measures, if they do not go, the fat doesn't go, then we have to resort to some sort of, energy based or some surgery which can correct the contour of the woman. Basically, I am a hardcore IVF specialist, but because something I found very, very interesting and exciting in this field of gynec cosmetology. Basically, it is overlapped by cosmetic surgeon and dermatologist, but then since they do not take adequate interest, the cosmetic gynecology is coming up in a big way. Yes. And what about the video? हेलो नहीं, मैं वो मूट कर दूंगा.
आपका शेयर नहीं हो पाया. Zoom पे मेरा लाइव शेयरिंग स्ट्रीमिंग चल रहा है.
Oh, that is okay. That's okay. Yes. Yes. Okay, fine. Till the setup. Fine. Basically, this the presentation is including a lot of videos which I want to run. So definitely I need a laptop. Or yeah, I will later on. Yes, yes.
So if it is taking time and the next speaker is ready, we can take that.
Yes, yes. Very well.
And till that time, sir can set up the laptop. So your talk is ready, Ramanan sir? Please.
Sure. Take it.
Sorry, sir, for the technical glitch, but we'll change.
Sorry for the technical glitch. We will go for the next lecture. CT MRI imaging indications in day-to-day practice by Dr. Ramanand Yadav, sir. He has completed his graduation and post-graduation in radiology from Lokmanya Tilak Medical College and Hospital, Mumbai. He has work experience in following modalities for last 12 years: general, uroradiology, and gastrointestinal radiology, 2D, 3D, ultrasonography and color Doppler, CT scan and MRI, USG and CT guided interventions, interventional vascular radiology. Presently is working in quantum high-tech imaging, Mira Road. Ramanand Yadav, sir, please take over.
Good morning, all respected members of Indian Medical Association. Next slide. Okay. 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 All right. All okay? Okay. Good morning, respected members of Indian Medical Association. I, Dr. Ramanand Yadav, will be speaking on a very important diagnostic modality that are CT and MRI and their indication in day-to-day practice. Slide. Okay. We'll start with the basics of CT scan. CT scan is also known as computerized axial tomography in old literature. CT is based on a fundamental principle that density of tissues passed by X-rays are processed and they are made into the slices. These are some common indication of CT scan. CT brain, though it is largely replaced by nowadays by MRI brain, but it is still used largely in trauma cases as well as in case of suspected intracranial hemorrhage. CT MRI brain with limited MRI diffusion is also a very good modality for suspected case of stroke and intracranial hemorrhage in hypertensive patients. HRCT chest, you all know in COVID pandemics, is a modality of choice for any pathology of lung parenchymas. CT KOB and CT IOP are modality that are used for pathology in kidney, ureters, and urinary bladder in suspected case of ureteric calculus, bladder mass, and kidney masses. CT abdomen pelvis is still a gold standard methods for evaluation of any infection in abdomen, trauma cases, or tumors. CT spine and CT extremities are especially useful for trauma cases and its ability to make 3D images. CT PNS is especially a guide for the ENT surgeon for functional endoscopic sinus surgeries. CT oral cavity and neck are gold standard method for head and neck cancers, neck abscesses. CT orbit and face are very useful for trauma cases again, and its ability to make 3D images is a very good guide for maxillofacial surgeons. CT brain angiography, though nowadays largely replaced by MRI angiography, but CT pulmonary angiography is the gold standard method for suspected case of pulmonary embolism. These are certain advantages of CT brain. CT scan is painless, non-invasive, and accurate. A major advantage of CT image is its ability to image soft tissue, bone, and blood vessels at the same time. Unlike conventional X-rays, CT provides a very detailed images of many types of tissue as well as lungs, bone, and blood vessels. CT examinations are fast and accurate. In emergency cases, they can reveal internal injuries and bleeding quickly enough to help save lives. CT has been very cost-effective in many cases. CT is less sensitive to patient movement than MRI. And unlike MRI, implanted devices has no limitation for the CT scan. So we can do CT scan in pacemaker patients also. Since CT is real image modality, we can do CT guided biopsy and aspiration and interventions. Diagnosis by CT scan may eliminate exploratory surgeries and surgical biopsies. Next slide, please. There are some limitations of CT scan, like pregnant women should avoid CT scan and X-rays for the risk of unborn babies. And any female given IV contrast should avoid breastfeeding for first 24 to 48 hours, though risk is very less. Contrast reactions to the like allergic reaction to the contrast is known factor, but it's again a very rare cases. Children are more sensitive to radiation, so unless it's medically indicated, the CT scan should be avoided in children. Risk of cancer is, there is no documentation that the CT scan causes cancers. The risk is very low. There are some soft tissue limitations imaging. For example, brain, gallbladder, internal pelvic organs, and joints. For these organs, MRI is a better modality. Next slide, please. Coming to the MRI, magnetic resonance imaging makes use of magnetic properties of atomic nuclei. As you all know, hydrogen nucleus has single proton. So, and it is present in all water molecules, therefore in all bodies. So when we force strong magnetic fields to the hydrogen nucleus, they align and they act like compass. So this is a physics involved with the MRI. The basic necessary equipments in MRI are magnets, gradient coil, and radio frequency coils. Next slide, please. These are some common indications for MRI. MRI brain is almost replaced the CT brain for being more accurate, and especially MRI angiography, they can provide such a beautiful images without even giving contrast. That's a major advantage of MRI. For MRI brain angiography, neck vessels angiography, and renal angiography, it is almost replaced CT angiography for the same region. And especially for CKD patient, when serum creatinine is high, we can perform upper and lower lobe angiography without giving without giving IV contrast to the patients. In spine and MSK cases, MRI remains the modality of choice. Cardiac MRI, MRI abdomen, hepatobiliary system, MRCP, liver lesions and breast lesions, MRI play key roles. Especially in MRI pelvis, it is found to be more sensitive and specific than transvaginal sonography and all uterine anomalies and pelvic pathology. Next slide, please. Next. So what are the advantages of MRI imaging? First is non-invasive imaging techniques. There is no radiation, though no exposure to radiation. MRI images of brain and cranial structures are clearer and more detailed than the other imaging methods. MRI can detect abnormalities that might be obscured by bone with other imaging modality. As you know, in CT brain, the temporal lobe and brainstem lesions are easily missed. That can be easily picked by MRI imaging. I spoke earlier, MRI angiography can provide detailed images of blood vessels in brain without giving IV contrast. MRI can detect a stroke in very early stage and it's life-saving. Next slide, please. There are some limitations and contraindication of MRI, like pacemaker patients should not undergo MRI. Same is for cochlear implant patient. And before taking patient into the MRI magnet room, we make sure that patient is not carrying any metallic objects. Next slide, please. These are some common contrasts that we use in day-to-day practice in CT MRI. Contrast media are a group of chemical agents developed for the characterization of pathology, for contrast visualization. Diatojet meglumine is the contrast media used for ocular contrast in CT scan. Iodinated contrast is used for the IV contrast in CT scan, and all MRI contrast are gadolinium-based contrast. Next slide, please. What are the emergency uses of CT scan? As you know, the CT scan is a very useful modality in emergency department. In all acute abdomen cases, CT scan remains the first modality. In suspected case of urinary tract infection, urinary tract calculus, appendicitis, epiploic appendicitis, diverticulitis, suspected case of bowel obstruction, or any non-specific abdominal pain. And if you're suspecting pancreatitis and acute cholecystitis, it remains the modality of choice. And CT play important role in acute chest symptoms to rule out pulmonary embolism, pulmonary infection, pneumonia, and COVID-19 pneumonia. I assume and hope that COVID-19 pneumonia is gone so that we can all plan our vacation, except countries like Russia and Ukraine. These are emergency uses of MRI, especially in stroke patient. MRI is very sensitive and specific, and it can be a life-saving. For cerebral venous thrombosis, MRI is the modality of choice. There are some indication of emergency spinal MRI, like spinal cord compression in trauma cases, spinal infection, epidural hemorrhage in spinal trauma, demyelination with acute neurological symptoms. Additionally, MRI may be considered if there is concern for appendicitis in pregnant female, as we can't do CT scan in pregnant female, so we can do MRI if we are suspecting appendicitis. And in some cases, hip fracture, which are missed on CT and X-rays, we can do MRI. Next slide, please. So my take-home message is you should always call radiologist for any doubt to decide which modality is better, whether we should do contrast or not, and what will be further investigation. And if we find any lesion and we have to decide is it infective etiology or it's a tumor, we can do CT-guided biopsy. Okay. Yeah, there are some common mistakes in all radiology centers. We kind of call it as blunders. Like in post-cholecystectomy patients, reports में काफी बार आता है कि gallbladder is normal size and ecotexture. Patient surgeon से बोलता है कि आपने operate किया था, but इसमें तो gallbladder normal आया है. These common mistakes happens. And in female patients, we mention like prostate is normal size and ecotexture. This is also common mistakes. And male patient, uterus is normal size and ecotexture. This all happens because behind a successful radiologist, there is a typist behind it. So at Quantum High-Tech Imaging, me and my team ensure that on case-to-case basis, we communicate with the consultants proactively and make sure that errors are reduced. Next slide, please. Thank you all. Have a good day. See you in the evening. And happy Holi in advance.
Hello. Thank you, Dr. Ramanand Yadav, for giving a nice talk on CT and MRI in day-to-day practice. I had one question. During the pandemic, so many persons were exposed to the CT chest frequently.
Yeah.
I just want to know how much radiation as compared to the X-ray is faced by the patient.
Initial CT scan were like one CT scan were equal to like 200 of taking 200 of X-rays. But nowadays with the newer machines, the radiation dose has reduced significantly. It's almost 1 CT is equal to exposure to 50-60 X-rays. But with all the research that we found that there's no risk for the cancers, as we all came to know about in the newspaper and everything about the risk of cancers. There is no conclusive evidence is for the cancer and the radiation. So nothing to worry about.
Thank you, Ramanand sir. I request our chairpersons to felicitate Dr. Ramanand sir. Moving to next lecture, Mommy Makeover Bringing Back to Normal by Dr. Rajesh Koradia sir. Rajesh Koradia sir, please take the dais. We are still having our technical glitch. Sorry for the inconvenience. We'll move for the next lecture. For that, I invite our next MOC, Dr. Maya Prasad Madam.
We'll move on to the next session. And for that, I'll invite Dr. S.N. Agarwal, sir, to chair the session. Is he there? Yeah, Dr. S.N. Agarwal, sir. Agarwal, sir, everyone knows Dr. Agarwal, sir. He is the most eminent senior gynecologist of Mirabhayandar. He must have conducted over lakhs of surgeries and uncountable, with more than 50 years of clinical experience. I welcome Agarwal, sir. And with that, our next talk will be by Dr. Navneet Desai. Are we ready with the slides? We are ready with the slides? Yeah. Dr. Navneet Desai is the practicing gynecologist of Mirabhayandar. She is the director of Shovana Maternity Hospital and Joanna Mother and Child Care Hospital. She is the president-elect of IMA Mirabhayandar. We'll see her next year standing here. She's a trustee of BMA, managing committee member of AFG. I welcome Dr. Navneet Desai for role of magnesium in pregnancy. Welcome.
Thank you, Maya. Good morning, everyone. COVID has taught us of doing everything online, but there are always some technical issues associated. But this is a very nice initiative by Madam of doing it hybrid. Congratulations, Madam, on that. My topic for today is magnesium and vitamin D in pregnancy. To just give a brief about it, magnesium is a very essential mineral required to regulate the body temperature, nucleic acid, and the protein synthesis, with important role in maintaining the nerve and muscle cell electrical potentials. It helps reduce the fetal growth restriction and preeclampsia. Till the time they are ready with the slides, I can just give you a brief about magnesium. So magnesium also has a very important role in modulating the vasomotor tone and the cardiac excitability. However, till now, magnesium deficiency was not heard of because magnesium is there everywhere. It is there in food, in dairy products, in bread, cereals, legumes, vegetables, whatever we eat. But nowadays, because of the processing of these things, magnesium deficiency has come into role. Again, magnesium, the level measuring is very difficult because almost 99% of magnesium is intracellular. Common causes of deficiency, as always, are inadequate dietary intake, inadequate gastrointestinal absorption, increased losses through gastrointestinal and renal systems, and increased requirement, such as in pregnancy. There are very important complications of magnesium deficiency associated in pregnancy, like gestational diabetes mellitus, pregnancy-induced hypertension, leg cramps, and preeclampsia. And they are all treatable and preventable. All these further lead to low birth weight, intrauterine growth restriction, and preterm births. It has been recommended nowadays that a woman consumes 280 milligram of magnesium per day, and this requirement increases in pregnancy. So now coming, done? So with this preview on magnesium, we will continue with our topic further. It has also been noted that vitamin D is a very important factor. Everyone knows vitamin D plays such an important role in our day-to-day life and in so many diseases, prevention. Now, magnesium is a very important cofactor for vitamin D. Both together in the transportation, absorption, and also in the therapeutic action of vitamin D, magnesium is very important. You have to do next, huh? So keep on doing it. I will catch up. You can reduce the size of the slide because this is not the whole slide. It is too much of a zoom. Zoom it out. हाँ sir, सिर्फ magnesium ही दिखना चाहिए, बाकी कुछ नहीं दिखना चाहिए. So magnesium alone and vitamin D alone, they cannot act individually. Together, they have therapeutic actions. That is the basis of this slide, which I think will come very soon. Also, we give vitamin D right, left, and center. Once we come to know the patient is vitamin D deficient, we put the patient on 60,000 of international units of vitamin D. But again, this vitamin D can lead to magnesium deficiency because for working of vitamin D, magnesium is required. And once the patient already has low levels of magnesium, we supplement the patient with vitamin D. Whatever magnesium is there is utilized for the functioning of that vitamin D, and it further depletes the patient of magnesium. Various salts of magnesium are available throughout, like you have magnesium oxide to magnesium carbonate to hydroxide, citrate, lactate, chloride, and sulfate. The most commonly used salts nowadays are magnesium bisglycinate and magnesium glycine complex. They contain magnesium 18% by weight in each, but the bioavailability is almost 80% as compared to other salts where the bioavailability is 4%, 12%, and so on. So magnesium, again, for body's physiological function, it is a very important mineral, and about 25 grams of magnesium is found in body, and 53% of this is found in bone as a part of bone mineral. Coming to the common causes of magnesium deficiency, which I've already enumerated, they include inadequate dietary intake, inadequate absorption, increased losses through the GI and the renal systems, and again, pregnancy, because it causes more demand. And what it leads to is hypertensive disorders, gestational diabetes mellitus, preterm labor, and IUGR. Now, why it is a big concern? Because of all these causes again, it can also lead to eclampsia, placental dysfunction, premature labor, fetal growth retardation, and IUGR. We are done with the slides. So go to slide number 12. Next. So these are the slides which showed how vitamin D and magnesium, when magnesium is added, vitamin D deficiency is also improved, and how magnesium is required throughout the pathway of vitamin D for its transport and absorption. Next. These are the various salts which I've already mentioned about, and you can see glycine complex, it offers 80% of bioavailability. Next, slide number 12. Next. Here. Come on. So reasons for high need of magnesium in pregnancy are again elevated renal magnesium excretion, which leads to enhanced renal loss and which leads to decreased serum magnesium levels. Next. So magnesium plays a crucial role during pregnancy in preventing all these conditions, which we have already enumerated. Next, please. As already mentioned, there was this study done by IMACON and et al., which confirmed that oral magnesium supplementation given before 25th week of gestation compared with placebo was associated with lower frequency of preterm births, low birth weight infants, and fewer small for gestational age newborns. Next, please. So again, this study by SMEZ et al. Showed that magnesium supplementation in pregnancy was associated with lower mean arterial pressure in women, along with higher birth weight infants and fewer days spent in the neonatal care unit. Now coming to preeclampsia. Routine use of magnesium in preeclampsia reduces the pathophysiological consequences of preeclampsia, and it itself reduces eclampsia. Maintenance of magnesium hemostasis in pregnancy is crucial for appropriate pregnancy progression. Next, please. How does it act? It acts as a calcium antagonist regulating the CV homeostasis. It causes alteration in the total and ionized magnesium, which helps in the endothelial dysfunction improvement, and vasospasm causes high blood pressure. So increase in magnesium leads to decreased peripheral vascular resistance and increase in renal blood flow and GFR. And thus it has deleterious consequences of pH to mother, fetus, and newborn. Next, please. So treatment of preeclampsia with magnesium reduced the rate of eclampsia by 50%. And there is preliminary evidence that fetal hypomagnesemia may be associated with metabolic syndrome later in life. Next, please. Next. Next. So these are the various studies which again prove the same point, which I've already stressed till the time the slides were getting prepared. Next. Coming to vitamin D, everyone knows the role of vitamin D in pregnancy, and there is an association between low vitamin D status and multiple potential adverse outcomes in pregnancy. Therefore, vitamin D nutrition in pregnancy should be of global health interest. Again, this deficiency can lead to preeclampsia, low birth weight babies, impaired glucose tolerance, neonatal hypocalcemia, impaired growth and bone development, and fetal lung development and childhood immune disorders. Vitamin D homeostasis and functions to maintain the main important role of vitamin D is to maintain the calcium homeostasis, because it is very important during pregnancy and lactation due to fetal bone development. When extracellular vitamin D and calcium concentrations are low, that is normal during pregnancy, there is increased synthesis of thyroid hormone, stimulates a synthesis of calcitrol to correct calcium deficits, which causes increased intestinal calcium absorption, increased mobilization of calcium from bone. Restoration of vitamin D status and calcium balance allows the calcium accretion in the bones rather than bone loss on the face of increased calcium demand. So that is how vitamin D is very important. And these are, again, all the various biological functions which are regulated with vitamin D. And as already mentioned, lower vitamin D can lead to gestational diabetes mellitus. Next, please. They are not catching up with me. Next. Next. So this was a randomized double-blind placebo trial in GDM. 6 weeks use of vitamin D for 6 weeks improves the glycemic control, and markers of cardiometabolic risks were reduced. Again, magnesium is an underlying factor for GDM, which disrupts the glucose metabolism in pregnant women. And supplementation also controls the metabolic profile and pregnancy and improves the pregnancy outcomes. Next, please. Next, next, next. This was a study published in 2013 in Archives of Gynecology, which states that magnesium supplementation to prevent high blood pressure in pregnancy. It was a randomized placebo-controlled trial, which showed a positive relation between magnesium and control of high blood pressure in pregnancy. Next, please. Again, this was an article published in Biomed 2017, which was done on effect of magnesium supplement on pregnancy outcome. It was a randomized controlled trial where magnesium supplement during pregnancy could decrease the probability of occurrence of many complications, which I've already enumerated. So thus, there is enormous evidence, and it was also there in the American Journal of Therapeutics in 2017 that magnesium should be considered as an important aspect of vitamin D treatment. Next, please. So subclinical, this is said by the WHO, which says that subclinical magnesium deficiency is common and known to decline during pregnancy. And vitamin D deficiency, vitamin D treatment, and pregnancy, that is third trimester and lactation, are listed causes for SMD. Next. Also, magnesium is a key vitamin D cofactor, and high dose of vitamin D3 alone induces severe magnesium depletion. Bioactivity of vitamin D is a magnesium dependent process, and clinical benefits of vitamin D are significantly reduced in SMD. Safety issues on vitamin D, they say vitamin D up to 1,000 international units per day is very safe, and this has been established into various studies. Next, please. Next. So thank you everyone for your patient hearing. Just one thing, keep the slides ready for the next presentations so that we can save on the time. Thank you so much. Sir, please, 1 minute. Yes, sir. Yes, Bhargav, sir.
Hello, hello.
Hello. Yeah, this was an excellent lecture, and I'd like to you to share with us, like what normal knowledge we have is that if somebody wants to get pregnant, you can start her on folic acid.
Yes.
Now, how do you proceed from there? Now, from first trimester, second trimester, third trimester, and where does vitamin D and magnesium you would prescribe them?
So see, again, in our practice, we cannot do serum vitamin D levels for all patients because all patients are not that affording. So there are two things. If the patient is repeatedly telling about some backache or muscle cramps or anything like that, I usually do not start empirical vitamin D. I always believe in doing the vitamin D levels and seeing for myself whether they are really low, and then putting the patient on vitamin D supplements. Coming to the magnesium and vitamin D3 combination for pre-eclamptic, if there is a known history of pre-eclampsia and last pregnancy, or if I get to know that the patient is going towards that on an NT scan report, if the sonologist tells me, okay, there is a probability that this patient is a high-risk patient for developing pre-eclampsia during pregnancy. So then after that, after the first trimester, I put the patient on all these supplements.
Madam, please share your prescription in first trimester.
So first trimester, it is only folic acid. If required, I give, if the patient has nausea, vomiting, then something on it. Otherwise, it is only plain folic acid. Second trimester onwards, that is after third month onwards, I put the patient on iron, calcium, and a protein supplement. If the patient is a low risk category, if the patient is a high risk category where we know the patient is probably going to develop preeclampsia, then those nitric oxide donors and these supplements of magnesium and D3 come into role. And then that is continued till delivery. Also, I do sometimes put my patient on aspirin, but then that is again, it depends upon my NT scan and all those reports. Thank you, sir.
Thank you, ma'am.
Thank you.
Dear friend, the magnesium sulfate is the one of the wonder drug, but we all obstetricians are afraid to use it. The magnesium sulfate we can give in the eclampsia, neuroprotection, or sometimes we can give for the tocolysis also. You see, in our Hindu culture, in the 7th month, we generally used to celebrate the antenatal day, and they used to go to the pond or talab and to have a puja, and they used to give the pan. Pan was the wonderful drug, wonderful substance. It contains a lot of magnesium. So in our puja, they generally the pan is the one of the essential item, and they generally, when they celebrate the pregnancy, they give the pan. So magnesium we are using from last so many years. It is not today, but nowadays, because we live in the city, all the ingredients are lost. So that's why we give magnesium orally. The magnesium, we should use all nursing home. They are the gynecologists, they must have a magnesium sulfate in their stock. And if suppose, if you give magnesium sulfate intramuscular or IV, you only should know the 3 R. One is the respiratory rate, second is the reflex of the knee joint, and third is the renal output. If you have a control of that, you can give bindas magnesium sulfate. Thank you, madam. Thank you. You have covered all the things.
Thank you, Dr. Navneet, for giving a nice talk on the role of magnesium and vitamin D in pregnancy. Thank you for maintaining the time also.
Thank you, Navneet, madam. I request SNR Goral sir to felicitate Dr. Navneet, madam. We'll move to our next lecture, Mommy Makeover, Bringing Back to Normal by Dr. Rajesh Koradia, sir.
First, attention please. First early bird prize goes to Dr. Jagruti Ghosh. I request Dr. Rakhi madam to please give the first early bird prize. Madam.
I have a small announcement to be made for those who are logged in online. For those who are logged online for MMC points, you don't need to put on chat. We don't need to put the MMC registration number on the chat boxes. What we have to do is make the payment and send the screenshot to Dr. R.K. Sharma. His name is given in the chat box. And Dr. Ashok Shukla, he is the observer for MMC point. Can I call the other chairperson, Dr. Rajiv Agarwal? Dr. Rajiv Agarwal will chair this session along with Dr. S.N. Agarwal. Everybody knows Dr. Rajiv Agarwal here. He is the past president of IMA, treasurer of IMA, and CWC member. Welcome, sir. Please, Dr. Mohan Agarwal, sir, please come on dais for the felicitation. Agarwal, sir, chairperson. Agarwal, sir. Navneet, Dr. Navneet Desai, for the felicitation. Just 2 minutes, huh? For the chairperson. Thank you, Dr. Navneet.
Okay. Good morning, everybody. Sorry for the delay because of the some technical issues which were coming up. So without wasting the time, let us continue with the presentation. My today's topic is mommy's makeover. Although I am hardcore IVF specialist, this is a special field which has generated a very special interest as far as my professional life is concerned. Till now, I was delivering lecture across the India and abroad on IVF. But I got opportunity to visit Spain and Israel for this newer technique, which was brought by the InMode. And this was the first installation of this machine and this technology in our hospital. I will take the opportunity to announce we are converting our hospital into, we are adding some high-risk unit ICU now. So these are some pictures. It is under renovation in next couple of months. It is going to be announced. So coming back to the topic, ultimate aim of all the women have the vagina with the Barbie doll look, which should be symmetrical, smooth, narrow, barely visible, minora, vaginal opening, appearance tight, little color details, nothing protruding beyond the minora. So there are some peculiarities of the vagina. Say, vagina has got at least 8,000 nerve ending. And if you compare it to the glans penis, it is 3,500 only. 3,500 only. So it is very sensitive area. But you should not, male should not dishearten. If you consider the whole glans and shaft, the nerve endings are 24,000. So much higher than a female vagina. The sharks and vagina have something in common. No, thankfully it is not the teeth. Instead, they both have a compound called squalene, which is found in shark liver and also in the vagina as a lubricant. So this is when the woman is aroused, this is secreted in the vagina. The vagina has a peculiar capacity to expand up to 200%, and that is why it can, deliver a baby easily. So what is the requirement of the mommy makeover? The mommy makeover is required to attain your pre-pregnancy look and feel, such as getting into a proper shape, having even skin tone, get rid of stretch mark, and to eliminate unwanted growth of hair, growth from all the parts of the body, and regain the vaginal health and look. So in simple words, it helps in gaining back the confidence. So what technology we use? We use three technology. One is bipolar radio frequency, another is IPL, a type of laser, and diode laser. So there are multiple procedures which we perform for mommy makeover. One is fat spot reduction, breast lift, stretch mark reduction, skin tightening, skin lightening and pigmentation removal, and reduction of the unwanted hair, as well as last is vaginal rejuvenation. So these are the different procedures which is performed with the help of these technologies. So we have divided, we have got dedicated cosmetic gynec unit, the name Bela. So we are performing these services in, we are offering these services in the Bela. So the mechanism, so first go for, let us think about how RF works. So the mechanism of the action of RF is energy is generated heat when it meets the impedance, and it is not absorbed by the melanin. So it is safe for the all skin type, unlike laser. First, it hit the connective tissue of the vagina wall and resulting heat shock, and which activates inflammation. There is collagenesis, elastin formation, there is neovascularization, there is increase in the nerve fibers, there is increase in the glycogen content, there is infiltration of the growth factor. So all in all, it revitalizes and restores the elasticity and moisture. So I will show you the video of body effects. That is a non-invasive fat reduction. Basically, this technology used for a localized fat connect, the fat, or when there is a decontour, the contour is disturbed. This technique is used. It is not for the weight loss. So this is an applicator having a suction and electrode with, it is applied like this. That part of the skin is sucked in and the energy is passed. And after some time, there is a very high voltage pulse wave, which causes the apoptosis of the fat cells and which is permanent. This is a non-invasive procedure. So it takes approximately 15 to 20 minutes, and this is to be repeated every week for a couple of weeks, and results are really good. So this is for who do not want an invasive type of procedure. There are a lot of control and safety mechanism in this. See, all these machines are available, Chinese, Korean machines. This is an Israel-made machine with a lot of safety features. Now coming to invasive liposuction. So you must have heard, these are the different technology of the liposuction, and almost all plastic surgeon, they use the energy-based liposuction. This is SAL, suction-assisted lipoplasty, power-assisted lipoplasty, water jet-assisted lipoplasty, and ultrasound-assisted lipoplasty. The heat-based liposuction is laser and use of radio frequency. See, heat, if you are using heat-based liposuction, it obviates a lot of problems which are there persistent after the energy-based liposuction, like laxity of the skin and pendulosity of the abdomen. All these are taken care beautifully with the energy-based liposuction. So what is indication? Basically, as I narrated, it is a basically localized fat collection. It takes care very well. How RFL, radio frequency assisted liposuction, how it is done. So this is applicator. There is a probe inside which goes in the subcutaneous plane, and the heat is passed from internal to external transducer. The internal temperature is 70 degree, and external is 37 degree. There are a lot of safety mechanism, a lot of sensors are there, which impedance control, certain rise of temperature. So it completely prevents the skin burn. And because of that, there is a coagulation of the fat, and that is melted. That fat cells are becomes apoptotic and necrose and goes away permanently. So the result, apart from that, the most advantageous part of this procedure is there is a contraction of the septa. Not only it coagulates the fat, but it contracts the septa, and because of that, there is an overall reduction in the diameter. So in approximately 6 months, you can expect at least 30 to 40% reduction in the thickness of the fat. So these are some results before and after. Now comes the forma, which is applied externally, and basically it is for dermal heating And so it helps in improvising the skin structure, which produces the new collagens, elastin, and grout substances. How it is done? So these are the applicator which are applied like this. The heat is transmitted in the dermis. There is a contraction of, there is no collagenesis, elastogenesis, and contraction of the deep dermis. So the creases on the skin, it goes away. I will show you the before and after picture. You can see. Now about IPL, that is intense pulse light. It is a type of laser visible laser which passes and which is absorbed by the chromophore, that is melanin, which is with the pigment and the hemoglobin which is present in the blood vessels. So it helps in removal of the pigmentation and the skin becomes bright. So with this, you can say it is a what do you call that? It is a Cinderella effect, and it is a photofacial. So photofacial. So somebody wants to go into some function, and she doesn't have time for going to the beauty parlor, or she's not getting appointment. The photofacial gives a better than the better effect than your facial. This is how it is done. So these are some results by IPL. You can see the difference before and after. These are our own patients. Taking with the same camera, see that you can see the difference in the pigmentation. Then comes the laser hair reduction. We use a diode laser. So you already know how diode laser works and how efficacious in hair reduction. It is done like this. These are our own results. You can see the reduction of the hair after 1 or 2 sittings only. Maximum 4 to 6 sittings are required. Laser hair removal after 3 sessions. You can see the difference. Now coming to the last part of the mommy makeover, that is a non-surgical vaginal rejuvenation. So normally vaginal rejuvenation, the patient asks for 2 reasons. Either it is a functional reason like sexual health is disturbed, or there is some urological problem like some stress incontinence or something like that. And another reasons are aesthetic reason. There is problem in the size, there is asymmetry, the displacement like prolapse, or maybe some color changes. Apart from this, we do a G-spot amplification. So it's a sensitive area which is with enriched innervation. It is located below the inferior to the urethra in the anterior aspect. So we inject PRP and collagen into these, and results are visible in 3 to 5 months. It enhances the sexual pleasure. The O-shot also has the same effect, in which the energy-based device is used, followed by the PRP in the vagina, and there are multiple points where we inject PRP. So it helps in female orgasmic disorder, female sexual arousal disorder, and hypoactive sexual dysfunction. So what are the advantages of bipolar RF, the vaginal procedure? That is Forma V, which we commonly do for tightening of the vaginal rejuvenation. It's a non-invasive. There is no adverse effect, no downtime. Procedure time is 15 to 30 minutes, and 87% subjectively improved the vaginal tightness in 6 months. It is best for mild ICUI and vaginal relaxation due to deep tissue penetration of the energy. Now coming to the labiaplasty. The labiaplasty is offered when there is a loss of elasticity and there is a wrinkled appearance of the vulva. There is a painful sensation because of the labial hypertrophy or drooping or asymmetry of the labia. And the primary reason for the patient request is aesthetic dissatisfaction in 87% and discomfort in clothing 64% and dyspareunia by invagination of the protruding tissue 43%. So these are the different reasons why they request labiaplasty. So how we do a forma V, that is a vaginal rejuvenation. Media not found. So this is applicator, gel is applied and the energy is applied in the vagina from top to bottom. Media not found. So this is our own result before and after. You can see only after a single procedure, only after single procedure. The left picture is before and this is after. This is also our own patient. You can see the difference. We add one more treatment to this is a Morpheus. So Morpheus causes 3-zone RF thermal injury. The nearest is ablation, then little on periphery there is a coagulation and there is a non-specific heating. Because of this, there is a coagulation of the fat, the contraction of the elastin fibers, neocollagenesis, contraction of the collagen fibers. So there is a overall reduction in the thickness and relief of the scar tissue. So at different level, this type of the injury, mechanical injury, electromechanical injury is done. How it is done? This is applicator of the Morpheus. This is a very good procedure in pregnancy stretch mark. It has to be done within 3 months after the delivery and results are very good. Apart from that, there are pimple mark or old acne mark on the face and there is a lot of irregularities, depression. So it helps and gives a fantastic result in this. The needles are protruding from the applicator and RF energy is injected, applied. It penetrates up to 5 millimeter. It is done under local anesthesia, Xylocaine local anesthesia, gel. So these are our own results. 2 minutes only. These are our own result. See before and after. You can see the difference. Acne. See the difference. You can see the difference. Before, after. Before, after. So what are the advantages of the RF procedure as compared to the laser? Because laser vaginal rejuvenation is also available. So there is no anesthesia which is required. There is no scarring, no pain during procedure. It takes 10 to 15 minutes and it takes care of the vagina, labia majora, minora, clitoris, and it is able to do the daily life activity right up the treatment. And last is acutite. That is injectable RF. We say it is a very advanced technique that is called injectable RF, and it is done for the labiaplasty, non-invasive labiaplasty. This way, after local anesthesia, the electrode is injected and energy is applied. And it's a very good procedure for non-surgical labiaplasty. It is done like this. The same procedure physically doing like that. Okay. So these are the labiaplasty result after 2 weeks. Only after 2 weeks. This is after 6 weeks. You can see the difference. After this RF energy, see the reduction in the size and symmetry. This is after 8 weeks. These are the different results. You can see and you can appreciate how much difference it makes. So if you combine the acutite with the Morpheus, it gives the best result because acutite works from inside and Morpheus works from outside. So this was the last slide. It helps in building up the confidence by shaping. See, a lot of people, there are a lot of women, they are coming up because till now, nobody was offering this type of the treatment. So we have to take a lot of effort to encourage and convince the patient. But gradually they are coming up and they have realized that this is really needed to build up their confidence. Thank you so much.
President to hand over memento to Dr. Rajesh Koradia. Let the MOC introduce the next speaker till that time, madam.
Hello. We have one more lucky draw, early bird registration coming out. And the early bird, Dr. Amol. Wrong name, we'll go to the next one. Okay. We'll go on to the next session by Dr. Niranjan Agarwal, sir. Dr. Niranjan Agarwal is a consultant laparoscopic and colorectal surgeon, Bombay Hospital, Wakad Hospital, and Salasar Nursing Home. He is the assistant professor in the Department of General Surgery, Bombay Hospital, Institute of Medical Sciences. He is the president of the Association of Colorectal Surgeon of India, executive board member of International Society of University of Colorectal Surgeons, and Vice President of the Federation of AMC India, Chairman of Network of AMC Hospital. He has got many publications and he has authored so many books. Over to Dr. Niranjan Agarwal, sir.
Thank you, Maya. Thank you, IMA, at the very beginning for giving me this opportunity. And a very warm morning to all my fellow
Excuse
colleagues.
me, Niranjan. I request all those who are sitting in the front and especially here near this counter, please keep silence. It is disturbing the speakers. Your volume is very high, please.
Thank you, Chairperson, for voicing my concern. I was about to say I have an obsessive compulsive disorder as far as when I'm talking and others are speaking in front. So I would request those who don't want to listen, please do not listen, but don't disturb others who want to listen, or at least not the speaker also. So keeping it brief because we have got time restraints. Anorectal disorders, friends, we all know something like pile, fissures, fistulas are so common in our daily practice that for us, when you write, it's a bread and butter for us, pile, fissure, fistula for a surgeon, like urine and stool are bread and butter for the pathologist. Piles and fissures or anorectum is bread and butter for the general surgeons. However, most of disorders are first seen by the general practitioners who, because of lack of infrastructure in his clinic, only evaluates them on history. And therefore, everything and anything which is related to the perineum goes as piles, you know. Any pain is piles, bleeding is piles, something boil is piles, everything comes bile. And that is not true. We all know that there could be so many other disorders, not only piles or not only fissures or fistula, they can be even cancer which can present as piles. So a timely evaluation may cause some serious delays to be avoided and therefore save much life. So today I'm going to talk to you about the recent updates, some of them, or take you through a journey of these few common disorders. Coming to the piles, apart from the definition which you should know, you should also know, which is more important, is that 50% of the population above the age of 50, like most 50% sitting here, I would say, will all develop piles sometime or the other in their lifetime. And it will equally affect both males and females. And they do have a tendency to run in families. And if a patient with below 20 years come to you saying there is bleeding pile, don't take it as piles because they are rare below 20 years. The theory of formations, not to go into detail because more of a surgical this thing, but just to enumerate, there is a sliding, because you need to understand the treatment which I am going to tell will be based upon the theory of the formation. That is one, sliding anal cushion. Then there is a failure of the intrinsic vascular mechanism, though there is hypervascularization, and there is rectal mucosa redundancy over there. This which we always talk in our practice there, because you are pregnant or your age, you piles, they are not actually the cause. They are only a precipitating factors like chronic constipation, straining, spending more time in towel, pregnancy, hereditary. They are all precipitating factors. They are not the cause. The types of hemorrhoids, we have got mainly 3 hemorrhoids. There is something called external hemorrhoid, which is seen outside, and therefore they are painful because they are covered by skin. Then there's something inside, which is called an internal hemorrhoid. They are covered by mucous membrane. They only can prolapse. Therefore, they are not painful. And then there are mixed, both external and internal hemorrhoid. You can see the pictures which I have put across along with the diagrams. And then there are grades of hemorrhoid. Grades means the severity. You can call 1, 2, 3, and 4. And this is my paper which we had project an additional suffix to that A, B, C, D, depending, because in your practice, you must have seen that not all the 3 piles which we commonly call are of the same grade. They may vary. So depending, if it is 1 pile, then it is A, it is more than 50%, then C, less than 50%, B. And this is what me and my colleagues had devised and published. And that is the Indian classification, which is now being quoted across the world so often. And regarding the grade 1 is one which is always inside, 2 is one which comes out but goes in spontaneously, 3rd is one which the patient has to push it back inside after the defecation, and the 4th one being which is always remaining outside. Symptom wise, mainly we all consider that pain should be a symptom, but it is not so. The 4 ladies on the 4th row should stop talking, please. Bleeding, this is what happens, the flow gets stopped. Sorry for that. So the main symptom is bleeding in hemorrhoids. There is a splash on the pan which is of fresh blood, and the quantity is small. It is usually after defecation, and if you continue to sit over there, the patient will keep bleeding. But if you get up immediately when the sphincter contracts, the bleeding will seem to have stopped. The second most common symptom is something coming out. The patient will say, or you ask them whether during defecation the mass comes out, they will say yes. And if they say it goes up when they finish defecation, that means it is grade 2, as I said. And if they have to push it back, they say then it is grade 3. If it is remain outside, then again grade 4. Sometimes they get itching because of the prolapse. There is a lot of mucus discharge which may cause soiling and itching over there. And anemia, of course, if there is a chronic blood loss in this patient. Pain, remember friend, is not a symptom of piles unless and until they are complicated. If there is a complication like I'll tell you the number, gangrene or prolapse or thrombosis, patient will not have pain. So if a patient complains of pain and bleeding, you must consider something else, that may be fissure or something. We will come to that. So pain only occur if it complicates. You require to do a proctoscopy to confirm your diagnosis. If you don't have the facility at your place, you must refer it to a surgeon who can do it for you and send back. And when do this patient mandates a colonoscopy or a sigmoidoscopy is very specific, because you don't want to miss a carcinoma in this kind of a patient. So anybody age above 45, those who have got weight loss, history of altered bowel habits, or history of positive family history, are all those patients who mandates a pre-operative sigmoidoscopy or a colonoscopy to rule out some serious disorders. So these are the complications like thrombosis, severe bleeding, strangulations, ulcerations, which may cause pain in this kind of patients. And as I said, it is not, bleeding is not only hemorrhoids. They can occur in fissures, they can occur in polyps, they can occur in carcinomas, so forth and so forth. How do you manage hemorrhoids? So the main aim is to relieve the symptoms and prevent recurrences. The whole therapy ranges either from a conservative treatment landing up to surgery, but none is perfect. It all depends upon the grades of the hemorrhoid, and each one has got its advantages and disadvantages. So for the first and second grade, which are the smaller hemorrhoid, lifestyle modification, because this is a lifestyle disease. It's a problem we have got because of our erect posture, and mainly in the urban areas you get more of this. So you need to correct this lifestyle, and it is true for all the anorectal disorders, to be very honest, not only for grade 1 and 2. And if you don't follow this, then the recurrence rates are very high. Then there are pharmacological agents which are present, which I will talk about. Third is a definitive treatment for grade 1 and 2, that is the office procedure. We can call either banding or sclerotherapy, or you use an IRC machine or a DG Hall machine. And slightly advanced can go for laser, radio frequency ablation, etc. What do you mean by lifestyle modifications? So as I said, required in all hemorrhoids, reduces recurrences. The most important thing is to have a soft bulk stools without straining. And this can be achieved by a high fiber diet or replacement of high fiber diet by bulk forming a laxative, that is isabgola, to the 20 to 35 gram per day. But only isabgol or only high fiber diet doesn't help. It is only going to make your stool more harder. So you are supposed to supplement equal amount of fluid. And how much fluid you should give? 1 liter per 20 kg body weight. So in an average of 60, you need to have at least 3 liters of fluid. But mind you, again, your cardiac and your renal functions should be within your normal limits. So your cardiologist or physician should permit you to take that much fluid. Apart from this, to avoid fatty and spicy foods, laxatives to relieve constipations, and most important nowadays, as earlier people used to take their newspaper into the toilet, now they take their WhatsApp. The first thing you get up, you first see what is the time in the phone, and the second thing, किसने क्या message भेजा है रात भर में, and वो pressure आ जाता है तो लेकर के टॉयलेट में जाते हैं और फिर पूरा रात भर का देखना रहता है सबको और बैठे रहते हैं, strain करते रहते हैं. So that should be avoided. Coming to the pharmacological agents, there are very popular ointments such as Pilex and Smooth and everything Innovate, and we use it left, right, and center for everything and anything in relation to the perineum. But it's not true. They are only symptomatic relief for a short period. They are not curative. At the most, in the long run, they may cause more harm because there is skin sensitization, especially the steroid-containing cream. And if this patient happens to undergo surgery, you can see that picture over there. The wound is very difficult to heal after surgery in such kind of patient. So it should be avoided for the long term. Among the tablets which are available now, the micronized purified flavonoid fractions are supposed to be the most effective, and the dose is not, you can't give 500 milligram BD/OD or something which you normally see. The actual dose is 1 gram 3 times in a day for the first 4 days, followed by 1 gram twice a day for the next 3 days, and 1 daily for the next 3 weeks minimum, or as you may consider necessary. They act by reducing the venous tone and reducing the venous stasis and increasing the capillary permeability. That is the only evidence as far as the other products which are there, Euphoria, Prostata, calcium double slate, they do not have very robust data to support their use. In fact, you can use micronized purified flavonoid fractions for immediately after surgery also, because that reduces congestion and edema, and therefore pain and bleeding to some extent are also supposed to be reduced. So when do you use MPFS? That is one in the early grade, that is grade 1 and 2, or pregnancy, patients with pregnancy in any grade, or patients with hemorrhoids with IBD, HIV, etc., where you do not want to operate, and in post-hemorrhoidectomy patients. They are unsuitable for external hemorrhoid or irreducible prolapse or strangulated or any complicated hemorrhoid. Coming to the office procedure, as I had named all of them, they all have got a result of around 60 to 80% success rate. That means around 20 to 30% are going to recur. And how do they act? They all cause some kind of vascular obstruction or some kind of fibrosis in that area, and they cannot be used in complicated piles or external hemorrhoids or those with associated disorders such as fissure, fistulas, etc. In grade 3 and 4, unfortunately, surgery remains the only choice, and that is the only option. But fortunately, it is required only in 5 to 10% of the procedures. And what do we have for surgery? Our conventional surgery, we have the stapler hemorrhoidopexy, we have the Doppler-guided hemorrhoid artery ligation, and the laser now. So the conventional hemorrhoid, which hemorrhoidectomy or the Milligan-Morgan or what we used to call, that is the open or the close, whether you have kept the wound open or closed, it depends upon that. Apart from grade 3 and 4, it can also be used in grade 2, which have not responded to the office procedure, or if you have got associated disorders in patients such as fistula, fissure, etc., will require some kind of an open surgery. In those patients, you can use that. Many patients, many doctors, especially in South Bombay, would try to lure you by saying we'll do an harmonic hemorrhoidectomy or a ligation hemorrhoidectomy. Friends, there is just an energy source which is there, which causes less bleeding. But as far as recovery, as far as the recurrences are concerned, there is no advantage in that. So hemorrhoidectomy, let me put it on record. this is a century-old procedure defined by Milligan Morgan in 1940, coming to nearly a century with the best result even today for especially the higher grades, and the most economical because you don't require any kind of extra instruments. And the only disadvantage, of course, that is the large painful wound and the time to heal and time off to work associated with the complications, which can be either pain, bleeding, urinary retention, constipation, sepsis, to name a few. So this is a small video. I'll just run through it because the first one is how we do it. That is, first take the pedicle stick because that reduces the bleeding to some extent. Now, this is not a malignancy, so don't exercise radically. To exercise whatever is necessary, the hemorrhoidal tissue, because at the end, you are supposed to leave normal bridges between the two cut hemorrhoids, the skin and mucosal bridge, because if you happen to damage the entire skin area over there, they will end up with contracture and there will be anal stenosis in this patient. So you can see we have taken a dumbbell shape. The anorectum is preserved because there is a role of anodum in the human body. You know, it helps in continence. So the more you remove, the more incontinences this kind of patient may develop. They are just one minute videos, so don't worry about it. So that was the open, and now when you close the wound, it becomes a close or a Ferguson hemorrhoidectomy. But only thing what one has to remember that when you close it, the suture line should not be under tension. The flap should come very easily, otherwise the sutures are going to break through. The other video which is started running is the harmonic hemorrhoidectomy, where instead of the cautery, you are using a harmonic scalpel. The next modality which is now available is the PPH, or that is called the procedure prolapsed hemorrhoid, or MIPH as is marketed in India. That is minimal invasive procedure of hemorrhoid, or actually the word is a stapled anopexy or stapled hemorrhoidopexy. It is not hemorrhoidectomy because we don't remove the hemorrhoid in this procedure. It is the prolapsed cushion and the prolapsed mucosa above, which is resected with the help of this stapler instrument, and the whole thing gets reposited back. It is used in grade 3, 4, and sometime in grade 2 where there is a failed office procedure. But most important, when patients have got circumferential hemorrhoids, you know, when we do a hemorrhoidectomy, you'll end up cutting more skin and then there is chances of more stenosis. Here you don't cut any skin. Your incisions are above into the mucous membrane, and therefore this is the procedure of choice for circumferential hemorrhoids. There's minimal pain. You can get back to work very early. There are no wounds to dress in the post-operative period. And it's a very easy procedure to learn for those who want to learn. There's a small video how it is done. This instrument consists of this circular anal dilator, operating proctoscope, which you insert. And then you take a purse string suture around 2 to 3 centimeters above the dentate line, complete the purse string suture. And then you have to, can I fast forward this? So there's a purse string suture which is taken, but the entire mucosa is supposed to be buried. You cannot leave any mucosa bare. So you have to be very careful, because otherwise that particular portion of the prolapsed cushion will not be taken into the stapler body, and that will lead to either recurrence or bleeding. In fact, this procedure costs lesser operating time also. You know, you can finish this in 10 to 15 minutes once you are trained in this completely. So this is the stapler which is opened, inserted inside, and the purse string tied across it on the shaft. Once you have done this stapler, these stitches are brought outside through the windows in the stapler body, and the stapler is fired. So this is how it is brought out. Sorry. I think it will not fast forward. The second last modality in hemorrhoid is Doppler guided hemorrhoidal artery ligation, where you ligate the terminal branches of the 6 terminal branches of the superior hemorrhoidal artery ligate, and you need to fix the mucosa above the dentate line. It is used in grade 2 and 3, but 4 it is not a good element, because 4 is mainly a prolapse. It comes out and remain outside. So this takes only care of the devascularization. I said you need to know the theory. So the hypervascularization element is covered, but the prolapse element does not get covered with this. And the last baby on the horizon now is the laser hemorrhoidoplasty, where you use a laser to kind of use energy inside the pile mass to vaporize the whole thing and cause fixation. But the results are only around 60-70%. However, if you add a hemorrhoidal artery ligation with the help of your finger, also you can feel the hemorrhoidal arteries and ligate, then it becomes a hybrid procedure and the results improves to around 90%. But and the advantage is obviously being no surgical trauma, reduce operating time, significantly lesser pain. When you get this pristine and all, which say no pain, no scar, they're all gimmicks. Actually, can a surgery happen without any scar? It can be a lesser scar, you know. So don't fall prey to all those kind of things. And if it is not used properly, as we always say, a fool with a tool is always a fool, still a fool, you know. So if you overuse the energy, this is what complications one can get and one should avoid. This is a small video of laser. So you redefine the grades of the hemorrhoid on table, palpate the branches of the superior hemorrhoidal artery and ligate them. And once all the branches which you are filling, which you feel or palpate rather, you know, you have ligated them, then you insert the laser probe through the mucocutaneous junction and deliver energy. The amount of, there is no shrinkage on table. Remember that the heat which is released will take its own time. There is a thermal heat and there is a time limit to that where it will start acting and then reduce it. So that's why we even use ice after this procedure. So this is the laser probe which is inserted and you can see the bright light of laser over there. You insert it on all the major hemorrhoids and burn them and withdraw. That's all. There are no wound. You see nothing coming out now, and this is the ice pack. This is the results. You can see pre-operative such large hemorrhoids, but gets reduced in the post-operative period. The benefits, of course, to the patient is it's lesser invasive, lesser bleeding, faster healing, can be done in a daycare. And for the surgeon, it is like you are using the advanced technology, you get a good name, and for the same thing which you have done in an open manner, you get more money. So Brijesh is nodding his hair because laparoscopy earns him a lot of money for the same thing which he can done in open. So again, the hemorrhoids in the special situations such as portal hypertension, actually they are anal varices. They are not hemorrhoids. You need to distinguish with them and treat portal hypertension rather than treating this as hemorrhoid, because that will lead to severe bleeding. In IBD, try and avoid as far as possible because wound healing will be a big problem. And there are many gynecologists over here. I would like to tell them all your piles are going to, most of 80 to 90% of them are going to resolve once the baby is delivered. What you need to go through is to tide over that patient over this crisis. But if the need happens that they are complicated bleeding and it is more than second trimester, you can take our help. We can do this hemorrhoidectomy or laser surgery in a left lateral position in the local anesthesia. So this is again from my paper, grade 1 and 2. We said lifestyle modification, medical treatment, then office procedure followed by surgery, and grade 4 only surgery. Second modality, second disease in common is the anorectal, the anal fistula, where are two phases, acute is an abscess and chronic being a fistula. It all originates as an abscess in the intersphincteric plane where there is an anal gland which gets infected and the whole thing bursts in various planes and causes a fistula. It is fortunately 95% of them are all because of infection in the anal gland, but then 5% can be either tuberculosis, inflammatory bowel disease, diverticular disease, carcinoma, etc. To classify, just because you should know the treatment modalities which we produce, the age-old classifications of parts like intersphincteric, transsphincteric, suprasphincteric, extrasphincteric is difficult to follow in all the patients. So a simple classification for clinician, whether it's a simple fistula or a complex fistula, makes all the difference. Simple are those with single opening, single track, straight track, no connection with adjacent structures. And even in a female patient, anterior place fistula are not supposed to be simple, even if they look simple, because the musculature out there are quite less. The rest all will fall into the complex, whether they are horseshoe, they are high transsphincteric, or they are extrasphincteric, supralevator, or they are associated with tuberculosis. Even recurrent or an abscess setting, they are all called as fistulas. clinically, these patients will present with the boil which comes and goes with discharge intermittently. Every 15-20 days, if the patient gives you an history, you don't even need to do a complete examination, but history itself will tell you that it is suggestive of an fistula in NO. The imaging, it's not required in all the patients. Nowadays, I see many fistula patients coming with MRI report to me. Not all patients should undergo an MRI. Only complex fistula, yes, definitely they should undergo an MRI because that's the gold standard. And never do a fistulography in this patient nowadays because it's more or less obsolete. Nobody does it anymore and it does not give you any extra advantages. So management, again, depending whether it's an acute presentation abscess or a chronic fistula or a simple or a complex fistula, or it's belonging to the cryptoglandular or a specific disease, your treatment is planned accordingly. The main aim is to identify and eradicate the infected anal gland and preserve the sphincter muscles around that, because if you don't do, a balance has to be stricken, and that is what which troubles most of the best of the surgeons. And whatever techniques are available, none of them are perfect, and none of them, you cannot say something superior to the other. There are various methods for simple, like simple fistulotomy, fistulectomy, and the newer methods such as lift, primary sphincter repair, or laser in this kind of patient. In an abscess sitting, the incision and drainage is the, I finished my time? 5 minutes? Huh?
Already exceeded your time.
If you are kind enough to give me what was it? Okay, thank you so much. I appreciate your kindness. So incision and drainage is simply done, but 40 to 50% of these fistulas will form an abscess, will form a fistula. So one can do a primary fistulotomy provided you are trained in doing your, in that acute setting, recognizing the internal opening, recognizing the sphincter muscles and doing it. This is how I do it. You aspirate, decompress the abscess, insert methylene blue, identify the internal opening, then you drain first thing the abscess, and then curate out the entire fistula and give a adequate drainage. Fistulectomy with sphincter, simple fistulotomy is still the gold standard for a low fistula, but for complex, doing a fistulectomy is not enough. You need to do something like a sphincter repair for these patients. And the other procedures which are not done, I will not talk much about them. A set-on is a very life-saving procedure for most of the surgeons, I said, not the patient. I say this because there you can be safe with the sphincters. This patient particularly was into septic shock, who referred to Bombay Hospital with an abscess in the vulva, abdominal wall, everything. And you can see what we have done is just tied a small set-on. We realized it's a fistulous abscess, so drained everything and even sutured it back and just kept a set-on over there. In 1.5 months time, you can see the entire thing has healed. Similarly, this patient, I did it at Tanwar. Patient was again abscess in the popliteal fossa, drained outside, sepsis. We realized it's a fistula and then closed it accordingly. The newer surgical options are mainly sphincter sparing, and therefore they cause less incontinence, but the recurrence rates are very high. So I do most of in my patient, I do a primary sphincter repair, cut out the entire fistula, remove it and repair the sphincter on table, because that gives the 95 to 98% result with minimum incontinence, and that's also minor. These are small videos which I would not show you. I'll just show you some pictures. So such kind of complex fistula, you can see we remove the entire tract and do the sphincter repair. Again, here you can see recurrent fistulas with 3 opening externally. We have removed and preserved the skin flap and closed it back. Again, here 2 openings, same thing. This is a complex fistula with colostomy. This patient had colostomy done in Dubai and he had been referred here for waft. After 2 waft, the patient referred. Ultimately, we removed everything and closed it, and the colostomy also got closed. So this is patient with supralevator fistulas. Same thing we do. And this is with multiple openings. You can see we have removed each and every tract and preserved the sphincter. And at 1 or 2 places where you have divided, we have sutured it back. The new technique again is laser. Again, hybrid is better because only laser causes high recurrence rates, and hybrid where you mix laser with either video assisted fistula treatment or lift or low fistulotomy, that gives slightly better results. So here in this patient, young boy, 20-year-old with a fistula in the scrotum and the anterior part, we did a waft, we cleaned out everything and laser ablated the tract, and that healed. Here again, anterior fistula, we did a lift with laser, and here a horseshoe fistula, I did a low fistulotomy, removed the pathology from there, but the other tract we just did a laser ablation. So these are the results which are seen. Again, horseshoe, same thing. Sharsutra, most of you will ask. It's a chemical set on. Basically, the results are not better, but sometimes you get very severe pain in this kind of patients. So we'll miss this. We'll miss this. Fisher, I will just for the update of the people. This is a chronic fissure. The one was an acute one. The chronic one you can distinguish by the external piles, which you call. It's not an external pile. It's an external skin tag or a sentinel tag, as we call. That is for the chronic fissures, more than 6 weeks. So if you see an external tag, you can very well say patient may say kal se hua hai, kal se nahi. This is more than this thing which they have missed upon. And regarding the general measures we have talked, the chemical sphincterotomy agent. Now 80 to 90% of your patient of fissure in NO will heal completely with chemical sphincterotomy agent, especially with nifedipine or diltiazem cream. You need to use twice a day for at least 4 to 6 weeks. Those with recur again and again, or those who do not respond, those are the patients who will require surgery. And surgery, like you can use a sphincterotomy, internal sphincterotomy. Most surgeons are doing anal dilatation, which is not to be done nowadays. It is absolute and should be condemned because that causes a lot of incontinence, especially the minor incontinence, which we never ask the patient whether there is any urgency or when there is loose stool or control of flatus. So internal sphincterotomy, we divide the sphincter at one point in a closed manner, is the treatment of choice. You can do it in open or you can do it with laser also. And this is what is to be condemned. So thank you for your patience hearing, friend. Thank you, Chairperson, for giving me that extra time. And thank you, colleague, for patience hearing and not disturbing me while talking so much. Thank you.
Thank you, Dr. Niranjan. We are proud to have Dr. Niranjan in Mira Bhayandar. He is president of Mumbai Surgical Society. Then he's secretary of ASI, also trustee of AMC Mumbai, so with vast experience as a good general surgeon, senior general surgeon also. So hats off to him and a big round of applause for him. Thank you, sir.
I would like to call Dr. Rajesh Korodia sir to chair this session. Korodia sir, please come on stage. We'll move on to the next session. This is by Dr. Mahesh Prasad. He's a nephrologist. Yes, sir. Yeah. Dr. Mahesh Prasad is a nephrologist and transplant physician in PD Hinduja Hospital, Mahim. He's also the teaching faculty for DNB in Hinduja Hospital and medicine in ML Dhole Hospital. He's awarded with the Rekha Memorial Tanker Award for Indian Society of Nephrology and was appreciated by Governor Appreciation Award for Dialysis. He's active member of many national and international societies, and many paper oration has been presented by him. His key interest in kidney transplant and renal. Over to Dr. Mahesh Prasad.
Thank you. My presentation. How will it change?
Felicitation for the chairperson. Dr. Agarwal sir, SN Agarwal sir, please come over.
Tea coffee is also served at the other end. You can take your tea coffee and come back and listen to the lectures.
I would like to request Dr. R.K. Sharma to chair this session. Dr. R.K. Sharma is up. Please come. छोड़ दो नहीं नहीं चार्ज नहीं है ओके अभी ना ये करो ना चार्ज use another laptop. We'll take the next session now then. Huh? In the meantime. Is it so? हो गया? Tea break. For those who are applied for the for those who have applied for the MMC Credit Point and on Zoom, what they need to do is make the payment and send the screenshot to Dr. R.K. Sharma's phone number. His phone number is there in the chat box. Okay, there's no need to send message on the chat box. And Dr. Ashok Shukla is the observer for MMC points. If Dr. Aditya Manke is ready, we'll take his session first. Dr. Aditya. Sorry. Yeah, maybe we'll take that session first. Yeah, okay. Okay, fine. हाँ वही Because of some technical issues, I think we'll move on to another session by Dr. Sameer Sheikh. Yeah. Okay, Dr. Sameer Sheikh. Okay, I welcome Dr. Sameer Sheikh on stage. Please come on stage. Dr. Sameer Sheikh is a DM nephrologist, and he's done his DM from PGI Chandigarh. He received award from the best research in neonatology. He's worked as an assistant professor in KM Hospital and Sage GS Medical College, Mumbai. National instructor for advanced NRP and International Board of Certificate Lactation Consultant. National instructor for NAST. He's now a neonatology intensive care consultant at Iona Hospital, Mira Road. Over to you, sir.
Yep. So the presentation is much more sort of nice to watch.
The tea break is over, so all the delegates are requested to come back and listen to Dr. Sameer. Tea break is over, so all the delegates are requested to come and sit.
Me and Niranjan sir both can have silence in the hall. Sir can make everyone sit and keep them silent. I drive them everyone and make the hall silent.
Delegates, please. Next session is just going to start. None other than by Dr. Sameer Sheikh.
That was saying, sir, me and Niranjan sir both can make the crowd go silent.
Yes, yes.
He makes them sit everyone and make them silent. I drive everyone out and make the hall silent. Definitely, sir. I was standing there where your introduction is there. Sir, वो तो ऐसा है ना कि in delivery one has to cry, either baby or me.
Sir, we are requesting Dr. Samir to spare 5 minutes for as a standing comedy.
Wow. देखो सर, किसको? अरे वो आ जाएंगे. बसना सर. Great. So yeah, can we have the presentation? Yeah, the third from the last. Great. Can you put it on slideshow mode? Will you be able to change the slides, ma'am? That will be great. So can I go freehand? Can I use this mic? Yes, please. Great. So we'll talk about outcomes of neonatal care. So plenty of time ICUs are fraught with that kind of a conception or sort of misconception that no one's allowed inside. Whatever happens in ICU, no one's allowed. It's not discussed anywhere. It's not shown anywhere. We show ICU as a as a glamour, as a facility which we glamorize. But we don't sort of disclose so many things, and plenty of time we don't disclose so many outcomes. What the any of the ICU have, let it be adult ICU, let it be surgical ICU, let it be medical ICU, let it be NICU also. So today we'll talk about, I spent a lot of time, those who have listened to me before, I've talked about basic neonatal care of a healthy newborn, how to take care of everything. We'll move a little ahead because we'll come to an end. I'll let you know that I'm starting a new chapter in my life. So with that, we'll talk about something about neonatal intensive care, which is sort of hidden or sort of pushed under the carpet a lot many times. So we'll talk about outcomes of neonatal intensive care and what does it mean? What does it mean to me? What does it mean to you? Next, please. So why I'm taking this lecture? Because overall, I may have thought, plenty of maybe thinking, maybe interacting from my colleagues, from my obstetric colleagues and everyone, that there are so many misconceptions goes on in the society. Ma'am, I'm not this fast. Can we go back? Can we go back? Perfect. So there are so many misconceptions in which goes on when I discuss the things with my colleagues and everyone, that overall neonatal intensive care is very long. Many people say that एक बार baby ICU में जाता है तो discharge ही नहीं होता है. Something like that. Plenty of time they feel that survival is meager. The baby is sick and goes to NICU. He will not survive. बच गया तो किस्मत है. Otherwise, baby is in ICU, he might not come back only. The service is very meager, especially as the gestation decreases. Okay, this misconception rises. So when I did my complete my DM and went for the first time in private practice, and I started interacting with obstetric colleagues, so many obstetricians in periphery, they said that baby was less than 1.5 kg or baby less than 32 weeks. We don't give them an option of transfer only. मैंने कहा why? ये तो बचने वाला ही नहीं है. So that was a shocker to me. That no, so we'll try to see that through, and definitely our conception is a different gestation, and plenty of time, again the misconception goes कि सर आप बेबी बचा लेते हो, वो पागल बन के घूमता रहता है आपके ओपीडी में, आपको क्या मजा आता है ऐसा देखने के लिए, कि पागल बच्चा आपने बचा लिया तो वो तो जिंदगी भर सोसाइटी बर्डन है. No, it's not like this. Okay, so baby who survives is not a burden on the society. They have a fruitful and very productive life. It's not a burden on society. We'll try to demystify those if the time permits. Next, ma'am. So first will duration of hospital stay, because that is what is more important when the care starts. Okay, from everyone, okay, even from your family members to an obstetric colleague who is sending baby to me, they need to know that for what baby is going to stay for how long. Next. So overall, this is a very nice study. You know, we'll try to stick to Indian data. This was a study which is done in Tamil Nadu in a teaching hospital. It was published in 2019. Huge study, almost more than 3,900 neonates were there. Next. So overall in this, the mean duration of stay in NICU of all the newborns were around 7 days. You know, when we just make an overall, all the gestation, all the weight, all the ages. So mean duration of hospital stay was just in 7 days. Almost 1% of babies even manage to get discharged within 24 hours of NICU. Out of them, baby who were majority of the babies, almost more than 50%, they got discharged within a week. Another major chunk which got discharged within something like around 15 to 20 days, or they didn't have a stay which is more than a month. So this is an eye opener for all of us. And if we see, if we try to combine those major chunk of population which comes to us, something like baby was a 1 to 1.5 kg, around 29 to 30 weeks of gestation, sort of very low birth weight babies, their overall stay was around 11 to 30 days only. Larger the baby, smaller the stay, smaller the baby, larger the stay. But still they could manage to go home nicely within a month. So this is a really eye opener for us. Next. Someone pay attention to me too. Next. And what predicts this duration of hospital stay? So for example, an obstetrical is referring the patient to me. They can also predict that yes, these factors are there. Baby might stay long. These factors are not there. Even the baby is sick. Yes, baby will come out very fast and very nicely. So this is a collaborative effort from Indian National Neonatal Collaborative Efforts, in which more than 3,000 babies from almost 12 centers analyzed. The data published on Indian Journal of Child Health in 2020, pretty recent data. Next. That every week in decrease in gestation, increase the length of stay by almost 9 days. So if you see the gestation, which started from 25 weeks to almost 33 weeks, the longest gestation was around 24 to 25 weeks of gestation, which was something like around 3 months. It decreased almost 33 weeks to around 10 days or so. So baby who is large, 30 to 33 weeks of gestation, week to 10 days of hospital stay is generally good enough. So there's not a single data study, because single center study, because plenty of time it depends on the kind of population you treat, kind of population gets referred to the center, and the attitude of the center. So plenty of them discharge criteria, other things are different. But if you collaborate from 12 centers across India, huge amount of data, more than 4,000 babies, and still we managed to come to a conclusion that babies who are this large of 30 to 33 weeks, around 10 to maximum 15 days of hospital stays, good enough. And even the babies who are very, very extremely premature, sort of ridiculously low birth weight babies, they even go home within 2 to 3 months. Next. What are the predictors? So just try to identify the predictor which are on the left side of the column in the table, not the right side, because that's the data. Okay, if you write it down, perfectly fine. If you don't remember, that's perfectly again fine. So what predicts the stay of hospital stay? Though, if this predictor are there, the stay increase by this many days. So the days which are on an average, that's on the out of the bracket, the range is inside the bracket. So taking an example, that abnormal antenatal Doppler. So if the Doppler finding abnormal, it can increase the length of stay by approximately 5 days, the range of around 3 to 7 days. So that's how it being interpreted. So abnormal antenatal Doppler, severe IUGR, requirement of resuscitation, any resuscitation at birth, respiratory distress, seizures, sepsis, NEC, major malformation, bronchopulmonary dysplasia. Here, mind it, the seizures and the sepsis are the major predictors, and the baby who are very severe IUGR, look at the amount of duration of stay, they increase approximately almost by 20 days. So keep it in mind when you are referring to SGA babies, even though they seem stable, okay, they can have a longer duration of hospital stay. Next. We'll talk about something about survival statistics, and if time permits, we'll go to the neuromotor morbidities and their outcome later in life. Next. So overall, this is a very nice study of almost more than 8,500 babies published in JAMA in 2020.
Yeah.
JAMA in 2021 about morbidity and mortality infants who are born extremely preterm. It was a pretty long, lengthy study of approximately almost 2010 to 2019, almost 10 years long study. This is mainly from China. I'm specially displaying this because majority of these ELBWs are surviving. The best rates are found in China and Japan. Japan still has a larger and better survival rates of extremely preterm babies than Western world. Next. So if we see the overall survival of this extremely preterm babies over 10 year period, overall almost more than around 60% babies managed to survive. This I'm talking about babies who are less than 28 weeks of gestation and less than 1 kg. At 22 weeks of gestation, approximately 5% was the survival. It keeps increasing. Almost babies who are 27 weeks of gestation, more than 70% babies managed to survive. So survival statistics is really, really good. If you say you want to cross the road, okay, your son or your family member is crying on the next side, you have a 70% chance of going through the road and 30% chance you might meet with an accident. What will you choose? Okay, we're talking about someone's loved one. The 70% chance is a good enough chance at 27 weeks, and definitely we should offer them. Next. Next. Yeah. So what are the predictors of poor survival? So baby who are SGA, yes, they have they don't have very good survival, especially on a long-term basis. Male sex, that's more of an epidemiological factor. Multiple birth, mother with a gestational diabetes, and low Apgar score. They are all independently predicts mortality later in life, especially babies who are less than 27 weeks of gestation. Next. So this is again a nice study which was published in Pediatrics 2017. It was the international comparison of 10 national neonatal network, and it was looking at a survival of babies who are less than 1500 grams and babies who are born within 24 and 29 weeks of gestation. So we'll see the data which are spanning across India and which are spanning across the world, that how they fare. So overall, still babies who are 24 to 29 weeks of gestation, overall almost 87% babies manage to survive. The survival is really, really good even in extremely preterm babies. And mean postnatal age at death, so those babies who didn't manage to survive, those 13%, almost all have died by end of first week. So take it the other way around. If such a small baby managed to have around 7 to 10 days of hospital stay, there are chances of dying goes from 87% to 13% only. So see that even the baby who passes just 1 week in neonatal intensive care, the survival chance becomes so bright that almost 90% of babies do manage to survive if they just go beyond 1 week postnatally in neonatal intensive care. Next. We have some time, 2-3 minutes more. Yeah. So we'll talk about neuromotor morbidity. The last part of it, that everyone tells me, those who don't understand neonatal intensive care, that sir bacha to lete ho, par sare, in exam case we used to have a long case, we used to have a neurology case where the baby is either cerebral palsy or a baby has some developmental disorders. So everyone used to say, Samir, you are the one who gives exam cases to all the pediatric students. So it's not like this. Let's go to that next. So if we talk about something which is worst outcome is cerebral palsy. The baby who doesn't have a good functional life, who's a burden on the sort of on society. So if we talk about cerebral palsy in the babies who are around 20 to 27 weeks of gestation, the chances is 14% only. Okay, the baby who are sort of not managed to survive till 24 weeks, even Indian government say that parents can have a say that they can take a chance that baby may not survive. They can take a chance and they have a legal right to say that yes, I don't want this baby. But still in those babies, the chance of developing cerebral palsy is just around 14%. It goes to around between 32 to 36 weeks, it's less than 1% only. So this is a huge improvement, that less than 1% chance of developing severe neuromotor morbidity in baby who are around 32 to 36 weeks of gestation. In such all babies, the hearing impairment is seen approximately in 3% of the babies, while it is approximately 1% in general population. So there is nothing great in it. So even the hearing capacity, we screen everyone, but yes, it is still very well preserved. And that is despite the all variety of neonatal intensive care available to us. Next. What about the developmental disorder? We talk about the bad outcome of cerebral palsy. We go to the finer aspect of development, where the developmental coordinate disorder, like basically autistic spectrum disorder, come into this picture. So what about this developmental disorder and about the minor neuromotor dysfunction? So just look at those red dots. So these are the different studies which has seen those outcome. So the first dot, the first red dot, less than babies who are 29 weeks of gestation. If we see them, less than 42% of the babies developed some amount of minor dysfunction. Okay, still 60% babies didn't had anything. So this is taking into account all type of small or larger minor disabilities, major disability and everything. Still 60% didn't have anything. So that's huge. Same way in the second part, baby was less than 28 weeks of gestation, almost 9.5% babies are found. So this huge amount of variation is there between center to center. So I've just taken those numbers which are smallest and which are the largest. So see those red dots. So almost 42 to 9. That's a huge variation in the developmental disorder which babies face later in life, or the babies less than 29 weeks of gestation. So that is really great that we fought with that idea. It's such a distressing idea given to the parents. So no, baby is not going to be developmentally all right. So many a time it is just our misconception, mental block, nothing more than that. Next. Same way about the cognitive impairment. Cognitive impairment was the sake of the analysis that was identified at IQ, which is less than 70. Again, see the red dots. So the first study, which was EpiPhage, which is the largest study, especially done in bigger newborns of 30 to 34 weeks of gestation, the range of developing such kind of cognitive impairment is less than 10%. The 10% is the highest number. So around 5 to 10% is the risk. So that is again really great. Same with the baby who are less than 33 weeks and babies who are approximately 24 weeks or less than 750 grams. The last red dot, again, it is just 46%. So babies are sort of not supposed to survive. In them also, the simple cognitive impairment is seen in less than 40% of the babies. So even if you want to give a grossest and the sort of worst estimate to any parent that how much problem the baby is going to face, so it's the mark is 40% to you in babies who are extremely preterm babies. So again, the neuromotor morbidity is not so huge. So we should not be sort of get carried away with that idea, or carried away with just a single lifetime experience that, and plenty of time our OPD experience is a biased experience. A baby who comes to you because he needs you. Baby who doesn't need you don't come to you. So plenty of time babies are doing good, they don't come to you. Baby who is mentally challenged, who has physically challenged, has developmental issues, will keep coming to you. And we get biased. Nahi, iska to NICU stay tha, dekho, ye to aisa hai. So plenty of time we don't see, we get biased opinion because we don't see the babies who are doing good and they are the part of the society because they now got mixed in the society. They don't come out, stand out from the crowd. Next. So summarizing it overall, the neonatal intensive care is not as lengthy as we think. Duration of stay can be predicted. You have predictors in your hand. So before referring even up a single patient, you come to know that how long the baby is going to stay, and these risk factors are there which can make the stay long or longer than expected. Preterm babies have very good survival and a chance of good functional life. A simple few numbers or odd experience of a life should not scare us. So the onus is on us to give newborns that chance to survive and have a fruitful life. Next. So at this juncture, as I told you, I'm starting a new chapter in my life. So I invite all of you as I venture into neonatal intensive care of my own. I'm starting a 20-bedded newborn hospital. So the inauguration is on 19th, that is next Saturday. It is 11 a.m. onwards till you arrive. So please make it convenient for all of you to attend. I cordially invite you and I would be love to have you there. Thank you so much, ma'am. Thank you, sir, everyone.
Thank you, Dr. Sameer, for short and crisp talk. So I want to impress upon our obstetricians colleague. Kindly do not tell the patients कि साहब 1 से 2 दिन लगेगा. Usually they say कि साहब 1-2 दिन रखने का है, 1-2 दिन में आपको सब ठीक हो जाएगा. So just after 24 hours, they start grumbling. साहब अभी क्यों रखा हुआ है? हमारे में डॉक्टर ने तो ये बोला था कि बस 1-2 दिन का काम है. Kindly let the pediatrician or neonatologist decide how long the bachu has requires stay in the NICU? Thank you.
As an obstetrician, I would like to give one comment, because I'm practicing since last almost more than 28 years here, and we have admitted many critical babies under others ICU also. We have admitted many critical babies under Samir also, and I can surely tell you, and honestly I'm telling you, the stay under Samir, the similar kind of baby is much lesser as compared to so-called very called renowned neonatal center. So I give full credit to Samir's management, and I wish you all the best, and we are always with you. Thank you.
We'll continue with our next talk. Dr. Mahesh Prasad, please come. That's why I did.
Welcome, neonatologist. Afternoon, approving. A very good afternoon to everybody. Sorry for the glitches in between we had. Somehow the remote is not working. Can I have my slides, please? Yeah, now it seems. Next slide. And madam, please keep looking at me whenever I say next or do the next person. So I start with that. Next slide. So friends, as you can see, the kidneys are one of the most beautiful organs we have in our body. And it's not merely just a extensive network of capillaries. It has much more than this. Like heart, which gives, force to the blood. Kidney gives purity. And it gives actually promise to keep the homeostasis of water, electrolytes, and acid-base balance. Next, please. This is the glomeruli. You can see the tiny tuft. But what it does, it produces approximately 180 liters, 180, 190 liters of ultrafiltrate every day. That's a tough job. Next, please. And for this, to support this massive work, 180, 120 liters means you have near about 9 to 10 full buckets of water every day is produced by this tiny tuft. And to support this, you have a specialized structure in the kidney, which supports glomeruli from outside. You can see the epithelial where it's beautiful podocytes and numerous foot processes, which provide stability to the capillaries. Next, please. And for this massive work, you have specialized and highly multi-layer and structured tubules, right from the cortex going deep down to the medulla, specialized breast border cells in the proximal tubule, aquaporin-laden distal tubules, spatial gap junction. Next, please. If you cannot do it, please give it to someone else now. We are already late. Next. Before this, sorry for the actually it disturbing the flow, but for the after the highly processing the 180 200 liters of water, what comes out is just a 1% of the actual ultrafiltrate. That's like it's such a high degree of sophistication is not possible in any human made machine. The kidney does a lot of work, so you cannot just ignore it, calling it a filter. Next, please. And apart from ultrafiltration, it's doing so many other functions like production of many hormones. It's taking part in the gluconeogenesis. It's taking part in the drug metabolism and excretion. Next, please. You cannot ignore kidney, and you cannot ignore this facts also that approximately 1 crore CKD patients are there in India, and 1 lakh approximately getting added to this pool every day. Next, please. The problematic part is the kidney patients are getting younger day by day. Previously, it used to be the disease of 60 plus, 70 plus. Now you can see the 55, 50 years of age are having kidney problem. These are the most productive age group. So someone in this age group is having kidney problem, it means not he, but his entire family will get suffer because of this. Next, please. So it's not surprising if I say that the chronic kidney disease may be the 5th leading cause of death in India very soon. Next, please. So what are the treatment options we have for the kidney diseases? Either transplant or dialysis. Next. Dialysis, there are only 2 types of dialysis. One is the machine dialysis, one is the home dialysis. The home dialysis, it's also called the peritoneal dialysis, where the peritoneal membrane acts as an artificial kidney and does the work of the dialysis. And in machine dialysis, we actually use an artificial kidney to get the filter done. But look at this, the days after you start the dialysis, as soon as you start the dialysis, the mortality is around 40 to 50%, 50% in little younger age group and the 40% in those who are above 60, 65. Huge mortality rate as soon as you start dialysis. And if someone continue with it, even after at the end of 1 year, the mortality rate is near about 30, 35%. It's a huge percentage. Next, please. Look, the same figure from different angle, the survival rate. The mortality was 30, 35%. It means the 5-year survival rate is only 20, 25%. Those who are on dialysis started on time and doing, I suppose that the figure from the outside, where the people do maximum dialysis in a day, 3 times in a week. Many of them are doing 5 or 6 times in a week. Next, please. So the option left is the kidney transplant. Next, please. Look at the survival advantage. If someone is on dialysis, the 5-year survival rate is only 25%. Whereas if someone does a transplant, the survival rate increases tremendously. It's around 80%. Next, please. Whether the transplant is done, either the live donor or the cadaver donor, the advantage remains the same. Next, please. The kidney transplant not only increases the survival advantage, it also does so many other work, decreases, it reverses many of the pathophysiological changes associated with the CKD, because dialysis does only 10% of the kidney function. Next, please. So in spite of the obvious survival advantage, you know how many of kidney transplant, the percentage of kidney transplant done in India, it's all over, it's around 3 to 4%. In rural area, it's less than 1%. In urban area, it's around 3 to 4%. So it's like 90 to 95% people are still either they are not coming forward or they are not able to get the transplant done. Next, please. Next. So why the transplant rate is high? Is the surgery is too complicated? I don't think so. Surgery wise, the native kidney is not touched at all, and new kidney is placed in the right or left iliac fossa, and it's anastomosed with the bladder, and the vessels are anastomosed with the external internal iliac arteries. So it's definitely it's a complicated study. It's an extensive study. It's not that complicated. Next, please. Is this the donor evaluation or the recipient evaluation demanding too much of investigation or too much of sophisticated labs and all? No. For donor, what we need apart from the routine evaluation is just the function CT scan to see how big is the artery, how big is the vein, how big is the kidney, and the functional, the split function of the two kidney, right and the left kidney, how are they doing? Next, please. And for the recipient also, not extensive workup is required. What we need, the patient genetic workup, the HLA, to know what kind of antibody he would produce and what kind of antigens he will produce that antibody. Simple HLA testing, it's not that costly as well. Next, please. And in donor, we do another test, that is the presence of antibodies against that particular donor. This is the only two tests required. What is the genetic makeup of the recipient and is he having any antibodies against that particular donor? That's all. Next, please. And the transplant can be done. Transplant does need, it's a teamwork, it requires a good setup, but as a surgery is not very extensive or very complicated surgery, pre and post-op workup is also not very complicated and very, the costly one, can be offered and should be offered. Next, please. Look at this, then what are the barriers? Why the people are not coming forward? Obviously, the understanding, the misconception, the financial part is one of that. But apart from that, there are a few other barriers. I would just go through one by one through all these barriers. Next, please. Non-availability of donor. We all know that people, if there are family, I know that if someone in the family, a daughter or the wife is having kidney problem, they are abandoned. They're abandoned by their family members. People stop visiting family because they fear that they can ask for the kidney donation. So this is one of that. The next, please. But the things are improving now. We have something called cadaver transplant in Mumbai. We have, in fact, in Maharashtra, we have a pretty well set up cadaver transplant team, and the numbers are increasing. Then we have something called swap transplant. Then we have domino transplant. Next, please. So many changes have occurred, and because of that, the cadaver transplant rate is increasing. The awareness has increased. The government is coming up with new and new things every day. If someone donates kidney, then if that fellow requires kidney, he is given preference. Same in the case of live kidney donation. If someone has donated kidney and later on, if he or his family members kidney is failed, he is given preference. So the cadaver, and a lot of NGOs have come in, they are spreading the message. Cadaver rate is coming up. Next, please. The swab transplant, if you hear people saying they do not have the matched donor and recipient at home, for that they can go for the swapping, and it's permissible by the JTCC as well as by the law of the land. Next, please. There's something very interesting phenomena that's called the domino transplant. We have multiple, as a 5, 6, 7 pairs. The kidneys are not matching. One altruistic donor from outside, he comes, donates kidney, and the chain reaction starts. If he gives donate kidney to a family, then it's become compulsion to that family that they should donate it to someone else. Then the second family, they have to donate it to someone else. So that become a kind of reaction. It starts with an altruistic donor. Things are happening in this way also. Next, please. ABO mismatch. Next, please. The ABO incompatibility till 10 years before used to be a big no-no for the kidney transplant. I just share my experience, the 3-4 ABO incompatible transplant done in between 2018 and 19. You can see the blood group totally mismatched, and the antibody titer were as high as 1:4096 to 1024. Next, please. What is done? The pre-existing, before removing the pre-existing antibody formation is stopped with the help of rituximab or anti-CD24 monoclonal antibody. Next, please. The antibodies from the recipient blood is removed with the help of a special kind of plasmapheresis. Next, please. And their immune system is modulated with the help of IV immunoglobulin. Next, please. You can see the rate. The patient 1, 2, 3 patient done in last 2 years, the ABO incompatible, You can see the antibody titers. The antibody titers is as low as 5, 5, 5, 15, 35. And the recommended is 1 is to, anywhere 1 is to 16 is a good antibody level to do the transplant. Next, please. And look at this, the creatinine. The creatinine has gone within a year, the creatinine level has gone to, next please. And you can appreciate the smile in all of them, the faces. That this ABO incompatibility is no longer a contraindication for the kidney transplant. Next, please. HLA mismatch. Next, please. HLA mismatch means your genetic makeup is totally different from someone else's genetic makeup. And obviously there used to be question that that fellow kidney will be accepted by the recipient or not. The study is done. It's all my patient, 152 transplant in last 10 years. 78 were them of totally mismatch. The wife given to husband, husband has given to wife. That kind of the segment 78 totally mismatch, where you have half mismatch in 70 cases. Those were like the family member, the mother, father, sister, they have given to their relative. Next, please. Look at the 5 years graft survival rate. 3 mismatch, 2 mismatch is still the 5 years. This is the graft survival rate, not the patient survival rate. 70, 100, where you have 6 mismatch is still the graft survival rate is 55. Means this fellow, those who have given totally mismatched kidney, their kidney will also last for near about 10 years. And after that, he can go for the next transplant as well. Next, please. Anti-HLA antibody. Sometimes you have antibodies against different types of, just like the blood group antibodies, you have anti-HLA body, you have antibodies against the HLA. That's a very difficult set of people to do transplant with. I just shared 3 of my patients' experience. Totally mismatched transplant, 3/6, 6/6 mismatched transplant, and all of them had good titers of anti-HLA antibodies. Next, please. The same thing was done. The antibody was removed with the help of IVIG, rituximab, and plasmapheresis. Next, please. Next, please. You can see the creatinine after 3 years, 1.2, 1.3, 2.7. 3 patients, their life expectancy has increased, their survival advantage has increased, and kidneys are working fine. Next, please. The smiles on their face tells a lot. Next, please. Other barriers like people who have HIV positive, people who have HCV positive, people who are having uncontrolled diabetes, people who are having moderate heart failure, the liver failure, extreme age. All these groups are also offered transplant nowadays. People do liver and kidney transplant together, left heart function. If it is more than 40%, they are offered kidney and they do quite well. HIV and HCV patients are also being offered kidney regularly. And stage cirrhosis, having hepatorenal syndrome, they need liver, sometimes they need kidney as well. They are also being offered. The kidney and the pancreas transplant is being done together in cases of brittle diabetes, having kidney failure. Extreme age group, if someone is of 80 or 90 years and doesn't want dialysis, he wants transplant only and happy and active life. There is no reason to say no. Obviously, the little risk will increase, but we are offering to them, a lot of our politicians, that they have done transplant after the age of 80, 85 years. So few of them are doing good. Next, please. So you can see the take-home message is the patient with CKD are more likely to die than go on to dialysis. Next, please. And the survival advantage if with one good transplant is much, much higher. Is at 5-year survival is 80 to 85%. Next, please. And it's not only the graft survival, you can see the patient survival rate is also increasing. Next, please. So the tissue and blood incompatibility, which used to be a highly contraindicated thing previously, 15 years before, 20 years before, nowadays we have good results coming out from the different centers that even if someone's blood is not matching, their genetic makeup is not matching, we can offer transplant. Next, please. And with the help of new medication coming out, like the monoclonal antibody, plasmapheresis, immunomodulation, the success rate is increasing day by day. Not only the success rate, but also the chances of repeated transplant is
2
increasing.
minutes more, please.
The last slide. Sir. Next, please. So let's spread the message that nothing but only one successful kidney transplant can change the life of a kidney, the patient who was suffering from the kidney diseases. So it's like instead of pushing the patient for the dialysis, one should push the patient or their relatives or their known to for the transplant, and the transplant should be done in time. That increases age as well as quality as well as the quantity of the life. Thank you. Next, please.
Thank you, Dr. Maestro sir. It was really enlightening, with full of message, and you made the topic very simple and removed a lot of misconception, including ourselves. Including being a doctor, we think that transplant is so difficult, so complicated. But then today we realize, so what about the general public? So really requires a lot of, public awareness, so that more and more patient can be taken. Yeah. Thank you.
I would like, sir, appeal ki, do something that with BMC and other people of Mirabhayandar, awareness on organ donation be continued from IMA side. It should be a topic for all days.
Dr. Mahesh, please move forward for felicitation. And we would also felicitate the chairpersons, Dr. Karodia, sir. Yeah. We'll move. I would like to invite the chairpersons for the next session. Dr. Bharat Kanse, please come on stage. Dr. Bharat Kanse is a senior pediatrician from Mirabhayandar. He is from GS Medical College, and he is director of the Mangal Murthy Hospital in Bhayandar East. He is past president of BMA and IMA and trustee of BMA. Welcome, sir. Our second chairperson for this session will be Dr. Vikrant Desai. Dr. Vikrant Desai is an eminent radiologist. He is the director at Tanishrav Diagnostic Center and Juvana Mother and Child Care Director. And he's the ex-president of IMA and BMA. He's a joint treasurer of AMC this year. Thank you. Welcome, sir. We'll move on to the next speaker. Our next speaker is Dr. Aditya Manke. Dr. Aditya is advanced laparoscopic and robotic cancer surgeon with more than 15 years of experience in surgical oncology. He's done his MBBS and MS from Grant Medical College and fellowship in surgical oncology at Tata Memorial, Kolkata. His field of expertise are robotic assisted cancer surgeries, laparoscopic surgery, and open surgery. And other expertise are all cancer, hepatobiliary surgeries, breast cancer, gastro, and he has also presented many national and international paper presentation. Over to Dr. Aditya. Welcome, sir.
A very good afternoon to all. So I am a freelancing laparoscopic and cancer surgeon. So I just started my practice at the time of when COVID came. So definitely many of us or many of you don't know me. So we know that 15 years ago or 20 years ago, when a patient would be diagnosed with cancer, there would be a question whether a patient will survive or no. But there has been a paradigm shift where now we don't think about survivorship because we have got better results. And definitely we are, as oncologists or oncosurgeons, we are focusing more on quality of life. How is going to be the quality of life? So as I told you, the quantity of life is not more important, but the quality of life is important. So suppose if a patient has even 1 year or 2 years, definitely he should have a good quality of life rather than giving him a 10 years of life with a very bad quality. And this is where minimal invasive or laparoscopic cancer surgery plays a very important role. So for us, it is a minimal invasive surgery, organ preservation and reconstruction for oral cancers, which is very much important for patients for improving their outcomes. So we all know most of our patients are frightened when they come to onco surgeon asking a very common question कि डॉक्टर साहब मेरा कितना बड़ा कट लोगे आप, कितना दिन मुझे हॉस्पिटल में रहना पड़ेगा, and definitely what is going to be the pain and post operative issues. When I was in residency, my bosses used to tell me that big surgeon make big incision. Most of the surgeons would agree with that, that 15 years ago, this used to be the trend, but definitely big things can be done through a small incision. So this is a slide which shows a open Wertheim cystectomy for a C endometrium, which we do. And now you can see that same can be done minimal invasive through laparoscopic also. So we all know what is the advantage of minimal invasive surgery. Smaller incision, cosmesis, less blood loss, adhesions are less, post-operative pain, shorter hospital stay. But still in a place like Mumbai, if you see, majority of minimal invasive surgery is limited still to gallbladder surgeries, hernia surgeries. And still I would put it at maybe 70% of cancer surgeries still done being open way. So why is that? So early misconceptions were there that whether we can be radical or no, control of bleeding in such major surgeries is possible or no, visualization of the anatomy, because people say if you open up, you see better for the critical structures, and port side metastasis. But definitely at the end of the lecture, you will agree that visualization of the anatomy and everything is as good as what we do it in open surgery. So role of MIS can be diagnostic, that sometimes you may not be able to get a CT guided biopsy at such locations that you may have to put in a scope, a curative intent surgery, and palliative procedures. So diagnostic applications, staging laparoscopy. Before a major case, we usually do a staging laparoscopy to see peritoneal mets are there. Resectability. So some patients may come, we don't know whether the tumor is resectable on the scan. There is a borderline. We can always put in a scope and see, and then decide to make a big cut. And biopsies from inaccessible or difficult slides. So just a small case. So we had a 60-year-old female with intermittent abdominal pain since 1 year. CT scan was suggestive of thickening in terminal ileum, right colon, omental stranding, minimal ascites. Now ascitic fluid cytology was negative. ADA was mildly raised. CA was 2.5. CA 125 was 34. And somebody outside planned for AKT for abdominal COX. All based on cytology. We did a diagnostic laparoscopy and it come out to be an epithelial ovarian malignancy. So importance is that you cannot rely on FNAC or cytology. A proper biopsy or visualization is must before treating patients. Again, then we had a 48-year female presented with recurrent abdominal pain, weight loss, CT scan suggestive of ascites, omental stranding, bowel thickening, and ovarian cyst. CA 125 was mildly raised, around 150. Cytology was said query malignant cells. And then somebody referred to me that, it looks like ovarian cancer, what to be done? And then we did a diagnostic laparoscopy for this patient. And you can see it came out to be a miliary tuberculosis. So we know that there is a ovarian cancer can mimic tuberculosis. And CA 125 can also be raised in tuberculosis mildly. And finally, it came out to be caseous necrosis. And then we started patient on AKT. Now, spectrum of curative surgeries in cancer, colorectal cancers, rectal cancers, gynae, endometrium we are doing, ovarian, very few select cases depending upon, what is the extent of the disease. Cervix, earlier we used to do, but currently 2 years back, we had a trial which said that laparoscopy is not a standard of care. So we have stopped doing cervix. Upper GI, stomach, esophagus, HPB, again, liver, pancreas in red, because yes, distal pancreatectomies you can do, but the evidence is against laparoscopic Whipple still now. And urological, again, kidney, bladder, prostate, definitely laparoscopy or robotic is more convenient. And then others like lung, thymus, thyroid. So coming to colorectal cancer, we know for a right hemicolectomy, you require again a midline incision. And this is what you can see here, that a very small incision and can be done through a laparoscopic way. Anterior resection again for sigmoid or rectum, big midline laparotomy. And this is on the right hand scar. You can see the minimal scar. Colorectal cancer, again, total proctocolectomy. So this case we had done about 1 month back at Mira Road. A very rare case, 40 years old patient presented with recurrent bleeding, had a colonoscopy done which shows familial adenomatous polyposis, didn't pick up a malignancy, but for FAP, we know that at the age of 45, 100% of patients will develop rectal cancer. So we planned him for a total proctocolectomy with a mucosectomy and an ileoanal pouch anastomosis. And you can see the beauty that the patient on post-operative day 1 is walking. And that is the power of minimal access surgery. Again, gynecological cancers, Wertheim hysterectomy or cytoreduction, again, we know it's an open incision. And this is what for endometrium, you can remove uterus, omentum, nodes, everything which can come out through the vagina. So I'll be just going through select surgical case videos. So thoraco will be starting with thoracolap esophagectomy. So we know that esophagus is a very, CA esophagus is a very morbid disease. So when these patients come to us, the surgery would entail the video is not. So sorry for the delay. So we all know that for an open esophagectomy, patient would require incision in the chest wall as well as the abdomen and neck. And it is a most morbid procedure. The mortality would be to a range of 10% or 15% with a lot of morbidity. ये वाला वीडियो क्यों नहीं चल रहा है इसमें? मैंने यहाँ पे चला, why it is not transmitting? Just give me a. So this is what you can see. We are opening. You can see the azygous vein there. So this is the thoracoscopic phase. We have started dissecting the esophagus there with all the nodal packets. And then again, we are dissecting below the esophagus. So below you can see is the pericardium or the heart is there. And we are clipping the azygous vein here. So this is how, and then you can visualize this is the bronchus, the right bronchus, and the complete nodal clearance of the carinal nodes is done. And the esophagus has been completely dissected till the neck inlet. And then we do it like a short abdominal phase where the complete stomach is being mobilized and we make it free from the GE junction. And this is how you can just see what's a very small incision we have taken in the abdomen. And this is how we have removed the whole stomach and the esophagus. And this is what we make a gastric tube. And the tube is again passed through the thorax into the neck. So your patient will have just 4 incisions on the thorax and a very small incision on the stomach. Then I will show you thymectomy. So we had this patient who had a thymus tumor, initially was unresectable, thymic carcinoma. So we planned for radical intent chemoradiation with chemotherapy done. But still again, after treatment, he did have a residual tumor. So we planned for a salvage thymectomy. So classical thymus would require a midline sternotomy. Now patient who has already received radiation chemo, the wound is not going to heal well. So we plan for a VATS associated. And now you can see the heart is there. And we are dissecting the lung of the thymic tumor. And this is the normal thymus tissue, which we are lifting it off the heart. And the tumor has been nearly lifted from the pericardium. So in certain cases, even if pericardial involvement is there, you can also do a pericardiectomy with the tumor. And you can see the ascending aorta there. So we are dissecting above the ascending aorta. So you can visualize the phrenic nerve. So this is the phrenic nerve. And this is the opposite side normal thymus tissue also, which we are removing it completely. So as I told you, this is for the classical thymectomy incision. And this was the post-operative, just minimal and a small access incision around 4 centimeters to deliver the tumor. So now I go to one more interesting case. So 15-year-old girl who presented with pain in abdomen, and MRI showed a ovarian mass and suspected as a germ cell tumor. So this is what the imaging showed. So we planned in for a diagnostic laparoscopy to see what it is. And her ovaries and uterus, everything was normal. And then what we found was she had a pararectal tumor. So tumor which was lateral to the rectum. You can see the tumor here. And it was basically a schwannoma. So we do have schwannomas, pelvic schwannomas, we can present as a pararectal tumors. And beautifully, they can be resected laparoscopically. You can see the ureter here. So we have dissected the ureter also quite away from the tumor. So this is majority of the tumor is out now. And this is what we have removed. And last video which I would like to show is for a lap adrenalectomy. So 65-year-old diabetic lady who presented with pain in abdomen. So she had a large adrenal tumor there. So you can see we are dissecting the colon of the tumor. So that's the tumor there. This is the colon. So here you can see this is the pancreas. So it was a left-sided adrenal tumor sitting below the pancreas. So we have dissected the pancreas completely off. So this is ligation of the adrenal vessel. And then completely dissecting of the spleen. So this is what the tumor which we removed, and the tumor was removed through a small phalangeal incision. And the patient was discharged on post-operative day 3. So that is the beauty of minimal invasive surgery. Definitely in India, we do get advanced cancers. So it is not like that open surgery is obsolete, but definitely we do have a patient pool which is getting diagnosed early, and definitely they require a opinion so that we can at least see, evaluate them that whether we can do it laparoscopically or no. And the future is going to be all about robotics. That is what people say. We still don't know in a place like India where price is still a constraint, where a robotic surgery would at least cost about 1.5 to 2 lakhs as a consumables extra. And then definitely laparoscopy is very easy to do. It's not that difficult in experienced hand. And it has changed the face of cancer care in surgery. Thank you.
Thank you, Dr. Manke, sir. This was an excellent presentation, and I do believe that using this technology or this procedures in whatever possible patients of oncosurgeries, it will give a better life to the patient also, and post-operative care would be also very nicely done.
So as we know, the patient do get discharged by day 3, day 4, all our colorectal patients. Even the proctocolectomy, which we did in Mira Road, was discharged on post-operative day 5 with a diverting ileostomy.
Especially in the patients who are of younger age, 30, 40, 50, whatever. So the productive age is more. So discharge would be faster, so that it will enable them to lead a pretty fairly normal life.
So even in older age group, we have seen that they do very well with laparoscopy. Only thing is that we do a 2D echo before to rule out that most of the times in older age group, the reason for doing an open surgery would be their heart condition. So because we use pneumoperitoneum, they may not be fit for an for a laparoscopic surgery. So these would be the group which would go for open surgery. But then definitely lap across all ages, whether it would be a 15-year-old girl or a 70-year. The adrenalectomy I did in on a 70-year-old lady who already had a CKD creatinine of 2 on medication. But then she was discharged on day 3.
Great, sir. Thank you. Thank you so much, sir.
I would just like to impress upon the talks what they are going physically as well hybrid. I think the level of the whole program has raised to such a level that we are all enjoying it. नहीं तो scientific session में इतने लोग बैठते नहीं हैं. Thank you so much. And hats off to all those on that side also.
Now, I'd like to call Dr. Rakhi Agarwal, Madam, to felicitate our speaker, Dr. Aditya Manke. Chairperson, okay, okay. Dr. Vikrant Desai and Dr. Bharat Kanse, sir.
Please, Madam.
Felicitate the speaker, Dr. Aditya Manke. So next speaker, I'm inviting Dr. Rahul Modi. Please, Dr. Rahul Modi is orthopedic consultant practicing in Kapadia Multi-Speciality Hospital, Goregaon West. He is MS, DNB Orthopedics, MNMS, Diploma in Football Medicine from FIFA, Fellowship in Arthroscopy, Sports Medicine and Shoulder Surgery. Dr. Rahul Modi.
Hello.
He is the youngest speaker. I would like to just say a few words. ये देखते देखते बड़ा हो गया. Dr. Rajan Modi sir लेप्रोस्कोपी के लिए बहुत सालों से आ रहे हैं. So he wanted to introduce his son. He's into arthroscopy, and I think so he'll do good.
Thank you so much. So thank you so much for the kind introduction. Along with being the youngest speaker, I think I'm the only orthopedic speaker in the whole forum. So and I see a lot of GI surgeons and other specialty. I don't think there is anyone who's an orthopedic here. So I'll try to keep it simple, and I'll try to make the talk in a way that everybody takes something out of it. So so as I practice in Kapadia Hospital, Goregaon West. But as I am an orthopedic arthroscopic surgeon, I do freelancing for arthroscopy all over Bombay and even out of Maharashtra and Gujarat and everywhere. So next, please. So my topic today is ACL and meniscus. So how do we treat it arthroscopically? And I would like to stress on the fact that here I am there to bust a few myths. So one of the most important myth that everyone has is that orthopedic surgeon is a carpenter. So that is one thing that I would like to bust, that yes, we are scientific carpenters, but we also do a lot of other things apart from fractures, and one of them is arthroscopy. So I'll like to talk to you about knee arthroscopy today. So knee is a very, very simple joint. It is one joint. There are two menisci in the knee. The menisci are basically shock absorbers of the knee, which protect the cartilage in a way. There are three bones or compartments. The three bones are the patella, tibia, and fibula. And there are three compartments, which is the medial compartment, the lateral compartment, and the patellofemoral compartment. There are four important ligaments of the knee, which is the ACL, the anterior cruciate, PCL, which is the posterior cruciate, and the medial and lateral collateral ligaments. And there are five muscle groups which cross the knee. So the first is the quadriceps, then the hamstrings, then is the iliotibial tract, then is the popliteus, and the last is the gastrocnemius. So it's 1, 2, 3, 4, 5. It's a simple joint. It's not very complicated. Next, please. So coming to meniscus tears, next. So meniscus, there are two menisci. One is the medial and the lateral menisci. As I said, they act like the shock absorbers of the knee. The medial is larger than the lateral. And next, please. Next.
So how do you diagnose meniscus tears? Meniscus tears are diagnosed by the important sign that there is pain on deep flexion, which is the first and most important thing. There is pain on weight bearing, and sometimes if a meniscus tear is large, it becomes locked and the knee becomes locked. How do you treat it? You either repair the meniscus or you remove the meniscus. Both are valid treatment options, and it depends on the severity of the tear, the site of the tear, and the activity level of the patient and the age of the patient. If neglected, meniscus tears can lead to what is called as early osteoarthritis. So somehow meniscus tears should not be neglected. Next, please. Coming to ACL tears, ACL is the most important ligament of the knee and the most commonly injured ligament of the knee too. The function of the ACL is to give rotational stability to the knee. So walking in a straight line is no problem without an ACL. Only when you twist and turn is when the ACL comes into picture. So a person with a deficient ACL can still be walking normally without any pain, and you will not know whether that patient has an ACL or not. The most common injury patterns of an ACL are either sports injuries or a road traffic accident or a twisting injury like fall while dancing. The most important thing when an ACL tear is that the foot has to be planted on the ground and the upper body rotates from the knee. That is the only way an ACL can tear. An ACL cannot tear when a person is walking in a straight line and falls down. There has to be a foot planted and there has to be a knee rotation. Symptoms of acute ACL tear are swelling, pain, a normal X-ray. The patient more often than not hears a pop when in his knee, and he's more often than not unable to walk immediately after the injury. The swelling and all subsides in a day or two. If the patient does not take immediate treatment in the first 2-3 days, the pain will reduce, the swelling will reduce, and that is why most ACL tears are neglected. The chronic symptoms of an ACL tear patient are, last slide, please. The chronic symptoms of an ACL tear are the patient will have persistent instability. So while walking in a straight line, as I said, he will not have any problems. As soon as he tries to run, jump, dance, he will have what is called as instability of the knee. He'll have recurrent falls, and the few complaints of a patient is that his thigh becomes a little thinner because the quadriceps gets wasted after an ACL injury. So these are some important markers that a general physician can also take through when he sees a patient with a knee injury, with a normal X-ray, and with all of these symptoms. If neglected, this persistent instability can damage other parts of the knee like the meniscus, the other ligaments, and therefore if you feel that a patient has an ACL tear, you need to examine him, and if needed, you need to get an MRI. So the most important question is, when will I get an MRI of the patient? How will I know that I need to investigate this patient further with a knee injury? So there are very, very simple parameters that you need to look for. Next slide, please. As in when to do an MRI. This is a very, very common question that all general practitioners and even telephonic consultations people face, ki MRI karau ki nahi karau. So if he's a young patient, if he hears a pop during the accident, if there is immediate swelling in the knee after the injury, and he has taken an X-ray and X-ray is normal. So all these things should, in an acute scenario, should make you think that yes, this might be an ACL tear and this might need an MRI. Now, when is the best time to do the MRI? Unless the knee is locked after the injury, immediately after injury is not a good time to do the MRI. An MRI should be done at least 2 to 3 weeks after the knee injury has taken place, so that the edema subsides, the swelling subsides, and then the MRI will give you a better picture of the injury pattern in the knee. Also, if he's a young individual, you should be a little more careful if the age is above 50, you can sometimes, neglect the injury per se. In a chronic, next please. In a chronic scenario, if the patient has not come to you immediately in a day or 2 weeks or 3 weeks after injury, the patient has come to you 6 months after injury, and he says, yes, I feel that my knee is giving way, my knee is buckling. He complains of recurrent locking of the knee, or he complains of pain on deep flexion and recurrent falls. This should, also give you an idea that yes, this might be an ACL or a meniscus tear, and I should get an MRI done. Next, please. So the advantages of knee arthroscopy. So all of these ACL and meniscus injuries are now treated primarily only by an arthroscopy. There is hardly anyone who does an ACL or a meniscus in an open manner now. So the advantages of knee arthroscopy. So firstly, let's get to the point that what is arthroscopy. Press the button, please. Next. So arthro means joint and scopy means camera. So it's exactly like in laparoscopy, but a laparoscopy or endoscopy goes into the stomach or the cavities, while an arthroscopy the camera goes into the joint. That's the only, it's the basic mechanism is the same. It's just the name is different. Now, the advantage of arthroscopy, like any laparoscopy, is that it is minimally invasive. There are less stitches, 2 stitches for a meniscus tear, 3 stitches for an ACL tear. The post-operative surgical pain is less. Keep pressing the next buttons, please. There is immediate mobilization. There is a short hospital stay. There is return to sports after an injury, which is possible. And the most important thing is there is prevention of osteoarthritis if these are treated well. Next, please. Another myth that I would like to bust, or another question that I would like to address for general practitioners or, people who are asking when should we do the surgery is, do all ACL or meniscus tears require surgery? So the answer is no. Next, please. Next. So which meniscus or ACL tears require surgery? So indications of meniscus surgery are very, very precise and fixed. Almost 80% of meniscus tears can be conserved. Why I say 80% is because 50% of meniscus tears are degenerative meniscus tears. So usually degenerative meniscus tears would not require a surgery and can be treated conservatively. The only type of meniscus tears that require surgery are either flap tears or bucket handle tears or radial tears or root tears. So I'll just explain you very quickly by the help of diagrams that what is a flap tear. So next, please. So when a part of the meniscus breaks and comes between the joint, that's called a flap tear. Next, please. What's a bucket handle tear? It's similar to a flap tear, but it's much larger. So the next, please. So it's right from the anterior horn going to the posterior horn, and sometimes it gets locked when this tone part comes in the intercondylar notch. So next, please. It shows. So this is a type of a locked bucket handle tear. A locked meniscus or a locked bucket handle tear will give rise to a locked knee, and that requires an urgent MRI and an urgent surgery. Next, please. Another type of tear that requires surgery more often than not is called a radial tear. It's through and through the meniscus, and that usually requires surgery because that acts like a complete meniscectomy. It's like the meniscus is not even there. Next, please. A similar type of radial tear, if it occurs close to the root, it's called a root tear. So these are the 4 types of meniscus tears which, according to me, would require surgery. Next, please. What are the indications of an ACL injury? So from the meniscus, we are now shifting to the ACL. Almost 40% of ACL tears can be conserved, but more often than not, if an ACL tear occurs in a young patient, if there is an ACL tear in a patient who's symptomatic, if an ACL tear occurs in the mid-substance, or if there are complete tears, these are the patients who would usually warrant surgery. So what is an insertional tear? Now, this is an important concept that people need to know, that some of these insertional tears do heal. So ACL basically is like a rope that connects the two bones together. And when this rope breaks from the insertion, there is a chance that this might heal. So there are two types of insertional tears. One is at the tibia and one is at the femur. Next. So these type of tears might heal, and therefore these can be tried to be managed by a conservative way. Next, please. But when an ACL tear breaks in the center, that is the mid substance tear, these type of ACL tears usually never heal. And these type of ACL tears, when seen on an MRI, we know that these more or often than not would require surgery. Next, please. I would like to show a rare case of a bilateral ACL tear. This is very, very rare. This is not very common. And of course, both of them operated in a single sitting is even rarer. I don't know of any. There are very few case studies which show that both ACL tears have. So in this patient, these two ACL tears occurred at two different time of injuries. Usually both ACL tears can never occur in a single injury. So that is the rule of the thumb, that two ACL tears, both knees cannot occur in the single injury, because never can it be that both foot are planted and the body rotates. It's only when one foot is off the air, one foot is planted and the body rotates, then only an ACL can be torn. So in this patient, one injury was 4 years old, one injury was 6 months old. He came to me, he was undiagnosed for this amount of time. And fortunately, for these ACL tears to be operated at the single sitting, the another prerequisite is there should not be an associated meniscal tear in the patient, because if we need to repair the meniscal tear, weight bearing has to be delayed, and then the patient would not be able to walk immediately after injury, after both knees operated together. So fortunately, this was a case when he had isolated ACL tears, no meniscal tears along with it. And I operated both of them in a single sitting, like a bilateral total knee replacement. I did a bilateral ACL reconstruction. Next, please. Play the video. It's a very, very small video of the examination. Yeah, it's the last slide. So this will just show a rough examination that, yes, this is the instability that the patient has in the left knee. That was called the Latchman test. This is the anterior drawer test, which shows anterior translation of the tibia over the femur. The similar thing in the right knee. My colleague is doing the examination, and similar anterior drawer test in the right knee. Both of them were operated on a single stage, straight leg raise possible on day 1 in both the knees. And because he had no associated meniscal tears, ACL patients can be mobilized on the immediate next day. So he was walking full weight bearing on both the legs. Next, please. And coming to the most important slide of all, thank you very much. I would like to thank all the organizers, Dr. Rakhi and everyone, to give me an opportunity for giving a lecture at such on this amazing platform. And I would like to answer any questions if anyone has some.
Yeah, you can answer the questions during break.
Yes. Okay. Thank you so much.
Thank you, Dr. Rahul Modi, for precise and enlightening the knee joint surgeries and meniscus tear and ACL tear, and enlightening about the partial and complete tear, when to operate, and for this minimal invasive surgeries. So the stay will be less. Thank you very much.
Thank you.
Also, in today's era, when all are getting very fitness freak, maximum times marathons and everything, the knee joint is the one of the most joint to suffer. So everybody should have that thing when the pain is, need to be diagnosed, and things have to be taken care of. Thank you so much.
So now I'd like to call our chairperson, Dr. Bharat Kanse and Dr. Vikrant Desai sir, to felicitate Dr. Rahul Modi. So next speaker, I would like to call Dr. Suman Chaurasia. She is MBBS MS from ESIC Medical College, Chennai, PDCC, consultant gynecologist, fertility expert, and laparoscopy surgeon in Okhad Hospital and Family Care Hospital, Mumbai. And she is also freelancing gynec laparoscopy surgeon in Mumbai. Welcome, madam.
Audience, please keep the silence because it's disturbing to the speakers. Please, and please keep the phone on silent mode. Okay.
Good afternoon, everyone. Myself, Dr. Suman Chaurasia. Thank you for the introduction and giving me opportunity. Today, I am presenting for laparoscopic myomectomy. Next. So laparoscopic myomectomy, it is the patient choice and comfort. So fibroids are the benign smooth muscle cell tumor of the uterus. They are extremely common, overall incidence of 40 to 60% by the age of 35 years and 70 to 80% by the age of 50 years. The precise etiology is still not known, but most importantly, it is mostly due to estrogen and progesterone excess. So we are describing the type of the fibroid according to the location, which is intramural, inside the uterine cavity more than 50%. Submucosal, it is out in the cavity, uterine cavity. Subserosal, outside the uterine subserosa, more than 50%, and cervical and parasitic fibroids. So this picture, we can see all the kind of fibroid. So this is the newer classification, FIGO classification. In that also, submucosal fibroid is coming in category of 0, 1, 2. And 3, 4, and 5 will come in intramural. 6, 7, and 7 will come in subserosal fibroid. And 8 will come the cervical and parasitic fibroid. 2nd to 5th, we are telling it is a hybrid leiomyomas. So this is the again picture. This is the MRI picture, where we can see and map the fibroids for the operation and the purpose of resections. So we come to the history. It was first described at 1979 by SEM, which was exclusively used for subserous myoma. From the beginning of 1990, the technique was developed to include the extraction of intramural fibroids also. So when we were doing pre-operative evaluation, we were using the techniques of abdominal ultrasound, vaginal ultrasound, Doppler assessment of the blood supply, MRI for the how many numbers and what are the position of the fibroid, sometimes diagnostic hysteroscopy for the submucous fibroid. Pre-operative evaluation, we are doing first the correction of anemia in the case of AUB, and GN analog for decreasing the size of the fibroid, which is controversial. Now these days we are using less. This is the previous old school thought, when the size of fibroid is less than 10 centimeter, that time only we are using laparoscopy. But now for 15 to 20 centimeter also we are using laparoscopy myomectomy. And where the number is 3 to 10 also we can use it. So we come to the technical aspect. Each myoma must be excised via its own hysterotomy incision. When there are multiple fibroid, we should not use the single incision and tunneling it. We should always use remove the first myoma stitches, and then only we can go to the second myoma. For the decreasing the blood supply and preventing the bleeding, we can occlude the uterine artery. We can use the clips in the uterine artery. And most commonly now these days, we are using vasopressin dilution, which is 20 international unit in 100 ml of NS, and we are injecting. Beforehand, we should inform the anesthetist to see the BP and patient's vital before the vasopressin injection. Then we have to dissect the myoma plane. So we have to always go with the one dissection plane, either use with the scissor or monopolar cautery. Avoid iatrogenic lesion in the bladder or nearby pelvic organ. Meticulous closure of myomectomy site is very important for the further fertility and for the prevention of uterine rupture in next pregnancy. So here is the boon for laparoscopy myomectomy. In 2008, Bab Suture has introduced for the myomectomy closure. After that, since 5 years, we are using it meticulously in all kind of gynecological procedure, even for the after hysterectomy, wall closure, myomectomy bed, we are using most commonly barb sutures. Why we are using it? Because the barb sutures reapproximate tissue with less time, cost, and aggravation. This is the picture of barb suture. This is loop barb suture, where we don't have to put knot inside the during the laparoscopic surgeries, and it is decreasing the time. This is the same surgeries. We are using introduction of vasopressin, then incision, then removing of the fibroid. Then we are closing it properly in 2 layers. Then this is the final picture. Then we have to we are removing the fibroid in the endobag. It is when we are having so much big fibroid, or we are having the risk of malignancy, that time we are using the endobag. But in foreign countries, we are every time using endobags. So this is the morcellator for removing the fibroid. We are using morcellator. This is electric morcellation. We can use even colpotomy incision also to remove the fibroid, and a small suprapubic incision also. This is the other picture. This is the post-operative picture. So extraction of the myoma, same I told. So outcome and complications. See, there is a conversion to laparotomy. It is variable. When there is a big fibroid, bleeding is there, that time it is 5 to 40%. What is the what's the factor is increasing the conversion rate? It is dominant myoma is in the broad ligament, anterior type location near the bladder, preoperative use of GnRH analog. In that situation, we are not getting the planes. So sometimes we have to convert it to the laparotomy. Now we come to the post-operative addition barriers. We are now these days so many augment substances there, which is decreasing the post-operative additions after the myomectomy. In that we are having barrier, which is called Interseed, coming from IMACON company. It is safe and effective, absorbable. We can use in laparoscopy also and laparotomy also. It is easy to use and cost effective. It is actually regenerated cellulose, site specific and cleared within 28 days. So first we will apply it in the dry surface in single layer after complete hemostasis, and then we will moisture it so it will stuck to the tissues. This is the picture of Interseed. Now, what is the outcome of laparoscopy, myomectomy, and infertility? When we are doing laparoscopic myomectomy or either open myomectomy, there is no difference in pregnancy and abortion rate. But for obstetric quality, we have to properly close the myoma bed in 2 layers, which is very much easy with barb suture, and it is a boon for the laparoscopic myomectomy. So now this is the last robotic assisted laparoscopic myomectomy, which is the future of it. Why? What is the advantage in it? 3-dimensional image we will get, absence of hand tremors, superior instrument articulation, comfort of the surgeon, and fast learning curve. Conclusion, laparoscopic myomectomy is safe technique, which is having several advantages, including less post-operative time, shorter recovery time, and reduced post-operative myomectomy additions formation in comparison to laparotomy. However, it is a difficult and we need a long learning curve in laparoscopic surgeries. Thank you, everyone. Thank you, IMA. Thank you, my colleague and seniors, for giving me opportunity to learn and do the cases. And I am really thankful, Dr. Rakhi ma'am, and my family for supporting me in laparoscopy and all.
Thank you, Chaurasia madam. And this was, I think, very concise and brief and everything about how to go about with the laparoscopic surgery of the myomectomy. And I think it was a very wonderful virtual journey of the operative procedure as well. So thank you so much.
Thank you so much, sir.
Thank you, Dr. Suman. So I'd like to call Dr. Rakhi Agarwal madam to felicitate our chairperson, Dr. Bharat Kanse sir, and Dr. Vikrant Desai sir. And first, we would like to felicitate Dr. Suman Chaurasia madam. Yeah. So now, felicitation for the chairperson. So I'd like to invite our next chairperson, Dr. Vivek Dwivedi, sir. He is eminent orthopedician in Mirabhayandar, ex-president IMA and BMA, and at present Zonal Director of AMC. And our another chairperson, our beloved Dr. Leela Agarwal, madam. She is one of the senior most gynecologists practicing in Mirabhayandar West. Please, madam. So our next speaker, Dr. Raghavendra Ramdasi. He is a consultant neurosurgeon, MBBS, MS, MCH neurosurgery, fellow of Association of Indian Surgeons, fellow of International Medical Science Academy, fellow in endoscopic transnasal skull-based surgery from Italy. Welcome, Dr. Raghavendra Ramdasi.
It's not you. Good afternoon. Sorry for keeping you waiting. But I won't be keeping you waiting for the lunch. I'll just finish it off as early as possible. Yeah. My today's topic of discussion is what are the recent advances in brain tumor surgery? We have a tremendous fear. It's not visible there. Yeah, thank you. We have a tremendous fear about brain tumors and the outcome of the brain tumors. What are they and how they can cause a morbidity in our life. But I would like to tell you that brain tumor surgery is no longer morbid. There are so many technologies which are developed, which are actually causing safe neurosurgery. So I would like to go through the brain tumors in brief. What is the incidence of brain tumor is around 4 to 5 per 1 lakh population. And the distribution of the brain tumor is most common brain tumors are secondary brain tumors, which are metastatized from the other part. And primary brain tumors most commonly are gliomas, meningiomas, pituitary adenomas, and vestibular schwannomas. The symptoms depend upon the location of the brain tumor. Okay, the symptoms depend upon, it's not working. Yeah, thank you. The symptoms depend upon the location of the brain tumor. Depending upon the lobes, the symptoms differ. So I don't want to go into the details, but the symptomatology varies with the location. So what is important for us is what type of headache is dangerous. So that one should know. So not all headaches are dangerous. So what are the red flags in headache? Early morning headache associated with vomiting, any headache associated with double vision, any headache associated with change in the mental status like confusion, personality change, or increased sleepiness. Any headache associated with seizure or motor weakness is dangerous and has to be reported. What is happening? So what is the treatment of brain tumors? Brain tumor treatment primarily is surgery, but the adjuvant therapy like radiotherapy and chemotherapy are also important. So the primary thing for brain tumor surgery is the microscope. So what is microscope? Microscope will give us the 10x magnification, but it doesn't give us the functional information. It tells us only the anatomical information, not the functional information, and it is two-dimensional. So the depth perception is not there. So we need to improve. So how to improve it? there are so many methods to increase the safety of brain tumor surgery. First is neuronavigation, then fluorescence imaging, neurophysiological monitoring, stereotactic surgery, and awake craniotomy. Briefly, I will tell you about each one of them. So what is navigation? Navigation is just like any GPS in our automobiles. It actually navigates the brain within the skull. We do a CT scan or MR scan. We do a CT scan or MR scan based upon this navigation system, and we reconstruct the two-dimensional image into a three-dimensional model. So we have this red dual camera system, which can actually track. What is happening? Yeah, I'm sorry.
What is the problem?
Yeah. So this camera system actually tracks the instruments as well as the tumor. You can see the instrument as well as the tumor within the skull. So how it is useful, the exact location and extent of tumor can be made out from outside. The most important application of this navigation is we can track the vessels, we can track the fiber tracks also from outside, and the relationship of this fiber tracks in relationship with the tumor. So we can locate the tumor from outside, plan the craniotomy. The smallest possible incision is possible. Obviously, the faster recovery is it comes. Then the exposure of the normal brain is reduced. So less damage to the normal brain, less damage to the vessels and the tracks around, and the tumor differentiation from the normal brain is easily possible. So this navigation system is a boon for a neurosurgeon. Then the second comes, what is a fluorescence imaging? Fluorescence imaging, we use the fluorescent dye like ICG or 5-aminolevulinic acid. The principle of this fluorescence imaging is that the gliomas, particularly the high-grade gliomas, they secrete a metabolite called as protoporphyrin 9. This emit a fluorescence, and we pick up the fluorescence with the help of the special filters in the microscope. So what happens, because of that, the tumor is visible as red on the background of black brain. So only the tumor is seen, not the brain. Then the third is a neurophysiological monitoring. We actually invasively take the recordings of the brain, the spinal nerves, cranial nerves, and spinal cord. It can be done at rest or by stimulating it. So where it is useful, any cortical eloquent areas, skull-based tumors and spinal tumors, we use it. So basically, as we can see it here, we have put a grid there. It is on the motor strip. So we can record the recordings from the motor strip and be away from the motor strip. So eloquent areas like speech areas, the motor strip, sensory areas, we can monitor during the surgery. Not only this, we can monitor the cranial nerves as well as the brainstem. You can see in a sitting position, we are operating a CP angle lesion here. We can exactly monitor the facial nerve. Then we can monitor the lower cranial nerves. So it is very useful for the skull-based tumors like vestibular schwannomas, then the glomus tumor. You can see we are able to achieve the complete excision of CP angle tumors. This is acoustic schwannoma without causing any deficit to the patient. Similarly, you can see the tumor, which is a schwannoma adhered to the spinal nerve. We can exactly locate the tumor and safeguard the spinal nerve. So this is about the neuromonitoring. Next comes the stereotactic surgery. What is stereotaxy? Is we can exactly locate the lesion and we can take the coordinates, and minimal invasive technique, we can actually achieve the accuracy of less than 1 millimeter. So you can see the tumor is in the brainstem. It's a very scary area, but still we can achieve the biopsy. We put the frame, we fix the frame, we take the coordinates and take the 4-quadrant biopsy, so that the tissue diagnosis is possible. We cannot excise the tumor in the brainstem, but nevertheless, we can at least take the biopsy. Nowadays, even the navigation guided biopsy is possible. So no need to fix the frame also. This is a navigation guided. You can see the picture where we have locked the trajectory, and in the center of the tumor, we can take the biopsy. This is a lymphoma. So the patient can be cured with this technique. There is a long history of awake craniotomies. 1,000 years back also the trephinations were done. But we learned the awake craniotomies basically from the epilepsy surgery. So for this, we need to know what is the eloquent cortex. We can see the eloquent areas are basically Broca's areas, the motor cortex, sensory cortex, Wernicke's area. So these are basically very important areas which can cause, means if we don't handle them properly, they can cause major deficits. So what we do in an awake craniotomy, basically is based on the principle that brain itself is not sensitive to pain. Strangely, only sensitive structures are the scalp and the dura. So during the opening of the brain, we keep the patient sedated with a short acting agent, that is Dexam. So as soon as we open with the craniotome, we awaken the patient. So full consciousness is achieved. So we can operate and talk with the patient. We can ask the patient to lift the leg. So exact location of the tumor in with respect to this eloquent areas, we can make out. So that is about the awake craniotomy. So next thing is endoscopy. Nowadays, we are using the endoscopy for neurosurgery. The scope of endoscopy is basically we operate the ventricular tumors, we operate the skull-based tumors. Also, the tumors which are located near the major cisterns, we can operate. So just to summarize, what are the newer techniques? We use awake craniotomy for cortical tumors, neuromonitoring for skull-based tumors, stereotaxy or navigation-based biopsy for deep-seated tumor like thalamic tumors or the brainstem tumors. Navigation we use for the tumors which are situated near the major nerve tracts or the vessels, and endoscopy we use for the ventricular lesions as well as the aqueductus stenosis. Thank you very much for your patient listening.
Thank you, Dr. Ramdasi. Thank you very much.
Thank you.
Excellent lecture, sir.
So just wait 2 minutes. So I'd like to call Dr. Vivek Dwivedi sir and Dr. Leela madam to felicitate our speaker. So I'd like to invite our next speaker, Dr. Preeti Sharma madam. She is obstetrician and gynecologist, Hitangchi Hospital since last 15 years. Her special interest in infertility, PCOS, high-risk pregnancy, adolescent health. She is also actively involved in MRMPA, BMA, MRMPA, NGO like Jaldhara and Beti Bachao, Beti Padhao, Doctor Cells of Mirabhayandar. Welcome, Dr. Preeti Sharma.
Good afternoon, respected seniors and my dear colleague. The capacity to learn is a gift. The ability to learn is a skill. And the willingness to learn is a choice. I would really like to thank Team IMA Mirabhayandar to give me this opportunity to talk in front of such esteemed seniors and my dear colleagues. So starting on with the topic. This is about redefining treatment approaches in bacterial vaginosis. As a gynecologist, the symptoms with which a patient come to us most frequently is white discharge, itching. Around 40 to 50% of our OPD consists of these type of patients. So I thought that I'll make a quick hurried go through all these slides. And since I'm the second last speaker between lunch, and so I just pay a little bit of attention, I'll finish it very fast. So we all know that lactobacillus are the dominant microflora of the vaginal system. This lactobacilli secrete biosurfactant, which helps in inhibition of addition of pathogens. It produces lactic acid, hydrogen peroxide, and acetic acid, which maintains the acidic pH in vagina. And it also secretes bacterocins, which inhibits the growth pathogen. Now, the female genital tract has already some immunity against the infection because it synthesizes protective mucus, it has an acidic pH, it has a tough stratified squamous epithelium, inflammatory reaction, and of course the presence of the lactobacillus. Now, urogenital infections are the non-sexually transmitted, namely yeast vaginitis, bacterial vaginosis, and urinary tract infections. And these remain a major medical problem in terms of the number of women affected each year. These are the most common reasons for which the women visits us or the urologist, and the morbidity and the discomfort caused is lot. So the bacterial vaginosis is an infection that is associated with a group of pathogenic anaerobic bacteria rather than only a single pathogen. Very common manifestation among the women of the childbearing age. This is the healthy vagina flora, that is 95% of lactobacillus, whereas in cases of bacterial vaginosis, it is replaced by Gardnerella vaginalis and certain other anaerobic bacteria, which includes bacteroids and Mobiluncus, Prevotella, Mycoplasma hominis. High concentration of these Gardnerella are found in 95% of the women with bacterial vaginosis, and they replace the normal flora, that is the lactobacillus. Bacterial vaginosis is the most common cause of vaginal discharge in the young women of reproductive age, and prevalence in India is around 20 to 40%. The predisposing factors include multiple sexual factors, douching or the washing or the cleaning outside the or inside the vagina with water with a lot of mixture of fluids, cigarette smoking, poor hygiene, various previously sexually transmitted diseases, and also intrauterine contraceptive devices. A lot of us see a lot of patients of vaginitis daily in and out in our clinics, and the differential diagnosis is between bacterial vaginosis, candidiasis, and trichomoniasis. Most of the females, those who don't have any discharge, or those are normal females, sometimes they do have clear to white discharge, but the vaginal pH is 3.5 to 4.5, and the KOH whiff test is negative. Sodium chloride wet mount shows the lactobacillus, which are the normal flora. But in case of the bacterial vaginosis, usually the symptoms they present is odor, itch, and discharge. This discharge is homogeneous, adherent, thin, milky white with malodorous, foul, fishy smell. The vaginal pH increases to more than 4.5. The potassium hydroxide whiff test is positive. And when the sodium chloride wet mount is studied, it shows the clue cells. Clue cells are nothing but the epithelial cells which are mounted by loads of bacteria. So this is seen in case of bacterial vaginosis. Other things that we see are the candidiasis and the trichomoniasis also. But in cases of candidiasis, the patient presents with lot of itching, discomfort, and a thick white curdy discharge. It is like a cottage cheese. There's a lot of inflammation and erythema around the area. But the pH is usually acidic less than 4.5, whiff test being negative. Few WBCs are seen, but basically on wet mount, we see that pseudohyphae or spores of non-albicans species. Trichomoniasis is the last one in which there's each discharge and there's a frothy or malodorous smell. Cervical petechiae or strawberry cervixes are seen, and the vaginal pH is more than 4.5. Usually when the wet mount is studied, we can see the flagellated protozoa. Complications of bacterial vaginosis includes that it can lead to recurrent pelvic inflammatory diseases, development of pelvic inflammatory disease post-abortion, vaginal cuff cellulitis following hysterectomy, risk of HIV acquisition and transmission, risk of acquisition of herpes simplex, 2, gonorrhea, chlamydia, and trichomonas infection. Various pregnancy complications include second trimester miscarriage, PROM, premature birth, and even endometriosis. Sometimes it leads to tubal infertility. Clinical features, sometimes they are asymptomatic. Around 50% of them don't have any symptoms. Sometimes they do have vaginal discharge, which is thin, homogeneous, and fishy smell. But if there's no discharge, it doesn't mean that she's not suffering from bacterial vaginosis. There is an AMSELS criteria, and out of these 3 criteria should be met before a patient or a woman is declared to be a patient of bacterial vaginosis. This includes a homogeneous vaginal discharge, pH more than 4.5, positive WIF amine test, and the presence of clue cells. There are Nugent scores for this. If the Nugent score is 0, it means that lactobacillus are lot in the vaginal flora, and so it's a healthy one. But if it is abnormal around between 7 to 10, it means that there are polymicrobial infection, there are clue cells, Coccobacillus, gram, variable bacteroids, and lactobacillus are very few. The management is very simple, and antibiotics, of course, are the mainstay in the therapy of bacterial vaginosis. We can give local application or oral administration of metronidazole, tinidazole, or clindamycin, and they are recommended also for the treatment of bacterial vaginosis. But then relapse and recurrence are very common. Why it is so? Because biofilm is a group of organisms in which organisms stick to each other and also to a surface, and that is the reason why they cause antibiotic resistance. The bacteria which are there in the biofilm, they are not eliminated by the immune body as well as neither destroyed by the antibiotics, and because of which these infections tend to persist and there is a high rate of relapse and recurrence. So biofilms are the main cause why if a patient first comes to us for bacterial vaginosis, we treat and then she keeps on coming again and again 3 months, 6 months or 1 year down the lane that the symptoms are not subsiding. It is because of the formation of these biofilms. Now, what are pre and probiotic? Probiotics are actually the living microorganisms which confirm a health benefit to the host when administered in a suitable amount like lactobacillus or bifidobacterium. Whereas the prebiotics are non-digestible food ingredients that beneficially affect the host by selectively stimulating the growth and activity of probiotic bacteria. Example, fructose oligosaccharides. Now, probiotics were discovered 100 years at the start of 20th century. The Russian Nobel Prize winner Elie Mechenkov got an award for this as he first conceptualized probiotics. What are the probiotics? How it works in bacterial vaginosis is that when we give them orally, they have a natural ability to migrate to the vaginal region from the intestine via perineal and the vulval skin. Probiotics are important because they maintain the vaginal pH less than 4.5. They also produce lactic acid, acetic acid, and hydrogen peroxide, which again helps in forming the acidic environment for the vagina. Also, the lactobacillus, they competitively block the adhesion of pathogens to the vaginal epithelium, and hence they prevent spread of infection. Also, they produce bacteriocins, and in vitro studies have shown that lactobacillus strains can significantly disrupt the Gardnerella vaginalis biofilms and hence inhibit the growth of pathogens. Now, differentiating between gut flora and vaginal flora, we see in gut flora there are a large number of flora like Streptococcus bacteroides, Enterobacteriaceae, Clostridia, and others, whereas in vagina it's mainly predominated by the lactobacillus. Foxy recommends the management of bacterial vaginosis, treatment of the screen positive, symptomatic pregnant or non-pregnant women, asymptomatic with high risk pregnancy, preferably to be treated before 20 weeks, and in women undergoing some sort of surgical procedure. The co-treatment with antibiotic and probiotic is recommended. Metronidazole 400 milligram is given twice daily for 5 to 7 days, or you can even give metronidazole 2 grams as a single dose, or you can give an intrametronidazole gel once daily for 5 days, or intravaginal clindamycin 2% 1 daily for 7 days. But probiotics like lactobacillus species like Acidophilus, Rhamnosus, reuteri, and fermentin, etc. should be given for 15 days. The rationale is that probiotics has been proposed as adjuvant to antibiotic therapy, whether you treat with metronidazole, clindamycin, or tinidazole. But lactobacillus probiotic preparation have displayed promising results in the treatment of bacterial vaginosis since they have been associated with high cure rates, low recurrence, and quick re-establishment of the healthy vaginal microflora. There are various clinical trials which has been done. I will not go in details of that. Patients were selected by AMSA's criteria, and it was done for the premenopausal normal females also suffering from bacterial vaginosis. And when at the end of 30 days, it was observed that the amount of vaginal discharge and the pruritus and the odor was much less in the group who were treated with probiotic given twice daily for at least 30 days from the day one of starting treatment. So these are the various studies that have been done, and all the graph tell the same thing, that the cure rate was 88% in the antibiotic probiotic group as compared to only 40% in the antibiotic placebo group. Also, all those who were treated with probiotic orally at the end of 4 weeks, around 96% of the females' vaginal microflora confirmed to be as lactobacillus was present. The natural microflora has been restored back. In summary, the study shows that efficacious use of lactobacillus and antibiotic in the eradication of bacterial vaginosis. The study demonstrated that oral probiotic treatment augmented the efficacious treatment of bacterial vaginosis with metronidazole. Now, there were various studies were done even with tinidazole, and the similar result were found. Prebiotic and the probiotic along with antibiotic has higher cure rate, low recurrence, and quick re-establishment of a healthy vaginal microflora. Various reproductive outcomes has also been studied, and it has been found that lactobacillus comprises 90 to 95% of the total bacterial count, and they are very important in various assisted reproductive technology also. And in infertility patient, it has been seen that if it's around 19% to 39% of the infertile women are having various different type of anaerobic microflora in the vagina. Similarly, bacterial vaginosis has also been associated with tubal infertility and also various preclinical losses. In cases of embryo transfer and vaginal microbiota, studies has been done, and it has seen that successful embryo transfer hinges upon many factors, including the presence of microbial colonization of the upper genital tract. Failure to conceive in ART is significantly associated with bacterial colonization of uterine cervix. So even if there's a bacterial colonization of uterine cervix or upper vaginal flora has been replaced, then also it leads to failure of the ART. So the microbiome profile that seemed to favor the achievement of pregnancy was dominated by lactobacillus, while the notable presence of Gardnerella species was associated with a negative correlation. There's a couple of the slides also describe about the same things. I'll not go in detail because the next speaker is ready and the lunch is also waiting. So I would say probiotics are very important in the patients who are undergoing ART because they help in recolonization of the vagina and offers an elegant and safe choice of treatment. Before ending my talk, I would definitely like to say something about female intimate hygiene, because a lot of females come to us using all different type of intimate wash and presenting again and again with these type of symptoms. Now the RCOG guidelines is that avoid using soap, shower gel, scrub, bubble bath, deodorant, baby wipes, and douches on the vulva. They all affect your vulval and vaginal normal lactobacillus. And so to summarize, bacterial vaginosis is very common. I've already told around 40%, and 50% of these ladies are actually asymptomatic. Some do have symptoms, but then always try to treat with the conventional antibiotic, try to include probiotics in the treatment. And with that, I would just like to say, excellence is not being the best. Excellence is not being the best. It is doing your best for the patient. Thank you so much.
Thank you, Preeti. She had given the good information about this chronic disease. There is no any treatment in the life.
Thank you, Dr. Preeti Sharma, madam. I would like to call Dr. Dwivedi sir and Dr. Leela, madam, to felicitate our speaker, Dr. Preeti Sharma. So we have reached almost our last segment for our academic session. So our last esteemed speaker, I would like to call Dr. Harminder Singh sir. He is very senior and eminent cardiologist. He has done MBBS from Maulana Azad Medical College, Delhi, MD from AFMC Pune, DM from All India Institute of Medical Science with gold medal, served Indian Army for 26 years, Associate Professor Cardiology, AFMC Pune. At present, he is consultant interventional cardiology, Bhaktivedanta Hospital, and director his own Meadows Cardiac Clinic. So welcome, Dr. Harminder Singh, sir.
Hello. Good afternoon, ladies and gentlemen. I appreciate I am standing in between you and the lunch, so I have a responsibility to finish early. I thank IMA for giving me this opportunity, especially Dr. Aki ma'am, who invited me personally. I am very grateful for that. I'll be rather brief, although the topic is interesting, but the time is most inappropriate. See, I'm basically going to talk about postural hypotension. It's, as I have written, it's underdiagnosed and undertreated entity. And we shall see as we go along the lecture. So I'll just present a case which I saw in the last about 20 days. 72-year-old male patient who has hypertension and was on telmisartan. He's also a case of MDR tuberculosis on second-line antitubercular drugs. He was on ATT already for 3 months, and he came with severe postural giddiness and almost tendency to fall, although he had no syncope.
Hello. Hello. Can we have your attention, please? Friends. Please start. Continue, sir.
Thank you. So the patient, when we checked up this BP, supine BP was 112. Standing at 1 minute, it fell down to 91. At 2 minutes, it fell down to 90. And on standing for 3 minutes, it fell down to 83/49. So you can see that the systolic BP has fallen by 29 millimeters and diastolic by 22 millimeters of mercury. Even then, this old gentleman did not faint. So imagine those people who have syncopal attacks must be having a much more fall of blood pressure. There was no neurological disease. ECG and echocardiography was normal. Now, with this background, this is a very common scenario, and we all must be seeing or at least hearing about such patients who fall in the toilets or get up and feel giddy, and many of our friends, relatives, and our patients are suffering from this. Now, a brief reminder of how the blood pressure is maintained. You can on the right hand see that there are a lot of inputs coming to the cardiovascular center, which is in the medulla. The input comes from higher centers, that is cortex, limbic system, and hypothalamus, basically our emotions and our thinking. A lot of sensory receptors are there in the aorta and the baroreceptors. And then the cardiovascular center gives the output to the various structures like heart and the blood vessels, maintaining the blood pressure. Now let's see about the chemoreceptors and baroreceptors. They are basically present in the arch of the aorta and also in the carotid body. And then the efferent comes through the parasympathetic and sympathetic nervous system, maintaining the blood pressure. Now you can see this is all neurological activity going on. So in serious neurological patients, this reflex arc is seriously hampered and they develop very severe postural symptoms. And this is how the feedback system goes. When the BP rises, the baroreceptors are they start activated. They reduce the cardiac output and cause vasodilatation. Blood pressure drops and the homeostasis is restored. The reverse happens when the blood pressure falls. Now this happens within matter of few seconds to a minute or two. So after suddenly rising, the blood pressure should come back to normal within a minute or two. So the reflex arc is so efficient and quick. Now this is what happens. The normal blood pressure we know is around 120/80. As the blood pressure keeps falling, it comes to low normal, then it below 90 systolic, it becomes hypotension. As the BP goes down, after a rough threshold of 50 millimeters of systolic, the brain circulation cannot be maintained and patient has syncope and may go into coma and death. Now these various figures are given as an example, but these figures may vary from patient to patient. Now we know there are a lot of causes of acute hypotension, which is not the topic for discussion. Sepsis, myocardial infarction, blood loss, hypovolemia, anaphylaxis, they all cause acute fall of blood pressure. And there are some conditions which are chronically hypotensive, like obstructive valvular disease, like mitral stenosis, aortic stenosis, left ventricular dysfunction, hypothyroidism, effect of drugs, Addison's disease, arrhythmias, poor salt intake and poor general health, frailty, and many of the pericardial diseases. So these do not form, this persistent low hypotension is not qualified for postural hypotension. And one very common cause of low blood pressure is a wrong cuff size. If you see a child's blood pressure or a thin lady's blood pressure with an oversized cuff, the BP will be low. Now coming to postural hypotension, the definition says that systolic fall of 20 millimeters of mercury and a diastolic fall of 10 millimeters of mercury within a period of 3 minutes. But if a patient is hypertensive, a systolic fall of 30 millimeter mercury from whatever is his baseline hypertension will qualify for postural hypotension. You see, unfortunately, we don't see it or diagnose it very often, but the incidence in blood pressure trials is almost 3 to 17%. In one of the ERIC trial, it was 5%. And when you see the individuals above the age of 65, it is around 20%. So it's fairly common disease. But if you see elderly people who are hospitalized, especially to the ICU, the incidence can be as high as 60%. So clearly it is under-diagnosed. Now there are various types of orthostatic hypotension. First is based on duration. One is the classical orthostatic hypertension, which the case I showed you. The fall of blood pressure happens within 3 minutes. Or it can be delayed orthostatic hypotension, which is beyond 3 minutes. Like in this example, the BP falls after about 8 or 10 minutes. Or it can be initial or immediate orthostatic hypertension. That means within 15 seconds of standing, the BP falls and the patient feels giddy or may fall down. Now, if we see the causative factors, we have two types, basically non-neurogenic and neurogenic. Neurogenic is when patient has a Parkinson's disease or multisystem disease or multiple strokes or severe spinal cord disease or neuropathies, they form the neurologic orthostatic hypotension. And non-neurogenic is all cardiac, all other causes are non-neurogenic. The main difference between the two is that in neurogenic, the sympathetic response is absent. So when the patient stands, the BP falls, but the pulse does not go up. In non-neurogenic, when the BP falls on standing, the pulse rate must rise by about 15 beats per second. That is the major difference. Now the pathophysiology, how it happens. You see, immediately on standing up, almost half to 1 liter of blood is kind of pulled into the lower extremities and the abdomen. Mainly it is in the abdomen because splenic circulation is highly innervated by sympathetic and parasympathetic nerves. And when there is disbalance in this particular system, lot of blood can get pulled into the abdomen, which we don't realize. And however, partly it also happens in the lower extremities. But this is a normal response. But this immediately is corrected within few seconds in healthy individuals, but it fails in those who are going to have postural hypotension. Old age is the biggest risk factor for postural hypertension because there is vascular stiffness, the reflexes, neurological reflexes go weak, and their response to adrenaline and other things is also impaired. The receptors are less responsive to the neurological mediators. So old people are especially at high risk for having orthostatic hypotension. Now, causes of orthostatic hypotension, as I said, they are basically neurologic, which is, you can see on the right hand side, there are a lot of diseases are listed. Normally we don't treat them. They're such severe diseases, they are almost always treated by the neurologist. On the left hand side, you can see drugs. Drugs is a very, very common cause, treatable cause. In fact, we must exclude all the drugs before we label the patient as orthostatic hypertension of idiopathic variety. Basically, the antihypertensives are the culprit: alpha-methyl dopa, alpha blockers, vasodilators like hydralazine, minoxidil, and diuretics, and psychoactive drugs, antidepressants, and other psychiatric drugs are also very common culprit. And once these drugs are excluded, we also must rule out acute causes, which we have already discussed, like bleeding, diarrhea, vomiting, excessive use of diuretics, and heart failure. So once we look at these three things, drugs, neurological assessment, and acute diseases, once these are ruled out, we call it as idiopathic orthostatic hypotension. Now, how does, other than the tendency to fall, how does orthostatic hypotension affect the patient's prognosis? It's a severe disease. It increases morbidity, mortality, because syncope and falls are very serious. They have head injury, they have CLWs, they have fracture neck of femur, Colles fracture, and spinal fractures, etc. There is increased incidence of stroke, increased incidence of heart failure. So it's not a benign disease. It may be a marker of severity, but once we diagnose orthostatic hypertension, we have to be very, very careful in treating these patients. Now, the mortality increases almost 1.5 to 2.5 times in various studies. Now, you can see on the left-hand side, all-cause mortality is increased in those who have orthostatic hypertension, coronary artery disease is increased, heart failure is increased, stroke is increased. These are meta-analysis of various trials. And the effect on the cardiovascular system is that there is increased chances of atrial fibrillation, atrial ectopics, and ventricular ectopics. And finally, there is increased left ventricular mass, and it predisposes these patients to heart failure. Now, how do we diagnose? We have already discussed in all those patients who have lightheadedness, syncope, pre-syncope, excessive fatigue, blurring of vision, cognitive impairment, which is posturally related. All these symptoms must direct us to check for postural hypertension. Why we don't see? Because we don't think of it. We are always busy. There is not enough staff for us to check it, because it takes at least 5 to 7 minutes to check for orthostatic hypertension. So it is many times we omit it. Now, this already have showed that there must be a rise of 15 beats per minute of pulse rate when the BP falls significantly, and that will differentiate it from autonomic failure. Lot of autonomic testing are there theoretically in the books, but we have never done it, never required to do it. There are various grades of orthostatic hypotension. This is of not much importance. I'll just come to treatment. Treatment is non-pharmacological treatment is the most important. We must avoid the triggers like large meals, hot baths, prolonged standing, and warm ambient temperatures like overcrowding in trains and buses and all. Patient should be asked to increase water and salt intake. Exercise is very, very important because exercise promotes the neurological recovery, and that sharpens the reflex arc of maintaining the blood pressure. And using physical methods like stockings for the lower limbs and abdominal binders. Abdominal binders are far more efficacious because maximum pooling is in the abdomen. Now coming to drugs, midodrine is a new drug which is available to us nowadays, is the first line drug these days. And age-old fludrocortisone is also available to us, but it is a second line drug. Guidelines recommend midodrine as the #1 drug. Droxidopa is there, is a neurological drug, but it's not available in India, so I will omit it. Coming to the main purpose of this talk is to sensitize all of you to this new drug, which is available and very useful. This is basically a alpha agonist, which is opposite of alpha blocker, that is we commonly use prazosin. It is the reverse of that. So it stimulates the alpha receptors and causes vasoconstriction. These are the various drug therapy which is available. Pyridostigmine is another drug, and atomoxetine is another drug which is not very commonly used by us, but they are very commonly used by the neurologists in neurological postural hypotension. Midodrine, the dosage is 2.5 milligram TID to start with. We increased it to 5 milligram TID. In the case that I have shown, the patient is now on 5 milligram TID. His postural fall has reduced to about less than 15 millimeters mercury systolic, and his giddiness is significantly less. We may even go to 7.5 milligram TID. It should be avoided during the night because when the patient is supine, it can cause hypertension. So nocturnal hypertension can be a side effect. So avoid during the night time. Last dose can be given around 6 o'clock or 7 o'clock. And the duration of action is about 4 to 6 hours. So if you give it around 7 o'clock, by 10, 11 o'clock, the effect will be gone and the patient will not get a nocturnal hypertension. The main contraindication, as I said, is very severe organic heart disease, uncontrolled hypertension. If a hypertensive patient has postural hypotension, midodrine not to be used. The drugs have to be appropriately modified. Then renal disease, prostate hypertrophy. It will nullify the effect of Urimax because it is a alpha agonist. So these people may develop urinary difficulties. So basically, this is little interesting, and many of you'll be benefited by this discussion. Apart from elderly patients with orthostatic hypertension, midodrine can also be used in hemodialysis patients. See, many of the hemodialysis patients develop hypotension during the dialysis. And classically, we tell them to omit the antihypertensive on the day of the dialysis. But if that does not work, so they can be given a dose of midodrine 5 milligram about 1 hour before the start of dialysis. This is very useful. Also, CHF cases, those who have symptomatic postural hypotension, because many of the CSF patients, the drugs cannot be discontinued. Diuretics cannot be discontinued. Many other drugs cannot be discontinued because otherwise the CCF will kill them. So midodrine comes as a very useful alternative. Now, in ICU patients, many times we are not able to taper off noradrenaline and vasopressin and other things. So if a patient is otherwise recovering, but the patient has delayed withdrawal of noradrenaline, Mirabhayandar can be tried. And this is a large trial where it has been found effective. Hemodialysis, I have already told. Sorry, this is the slide for ICU patients. Almost more than, there are 2 studies available of more than 1,000 patients where it helps us to taper off noradrenaline and other vasoactive drugs in ICU patients. In diabetics who have autonomic neuropathy, there also midodrine can be tried. So I'll conclude by saying some take-home messages. Orthostatic hypotension is a very common condition, especially in ICU and in our sick patients. General incidence is about 2%, in hypertensive about 5%, in elderly about 20%, and in CCU patients almost 60% incidence. Drugs and neurological disease are important causes. Diagnosis is by 20 by 10 millimeters mercury fall within 3 minutes. Heart rate should rise by 15 beats per minute. Non-pharmacological treatment are the most important and most easy to implement. And midodrine and fludrocortisone are the mainstay of treatment. Fludrocortisone is a second-line drug I didn't mention here. It is given as 0.1 milligram per day. Again, contraindications remain the same, that it can aggravate supine hypertension. Midodrine can be used, is a novel agent, can be used for vasovagal syncope, orthostatic hypotension, hypotension in ICU, and in dialysis-related hypotension. Thank you very much for your kind attention. And sorry for delaying you for the lunch.
Thank you so much, sir. So would like to call Dr. Leela Madam and Dr. Dwivedi, sir, to felicitate Dr. Harminder Singh, sir. And then I'd like to call Dr. Rakhi Agarwal, Madam.
There is one more talk. Please don't go. Food will start at 2:30.
And those who have not registered and didn't collect their food coupon, please go to the registration counter and collect the food coupon. So I'd like to call our next talk will be provided by AU Small Finance Bank. So requesting all who have not collected their food coupon, please go to the registration counter and collect it after these talk.
So very good afternoon, everyone. So I'm Chetan Rajput. Hello, is it okay? Very good afternoon, everyone. So this is Chetan Rajput. I am from AU Small Finance Bank, and I'm going to present how banking has turned to a digital mode. So wherein earlier we used to go to bank for every single transactions. But now bank is coming to home, bank is coming onto your mobile, banking is coming to your office, your home, your tablet, your iPad. So there's no need to go to bank, and all the transactions, every banking need is being done on your fingertip. So what does digital actually means? So digital banking is a present tense in banking. It's not just banking on internet, but it's much more, which actually involves the social, mobile, analytical cloud model, which put customer first and cuts the bank's cost. What is the benefit of digital banking? It's 24/7 access. Obviously, for any single transaction, as I mentioned, that you don't need to go bank. You're in office, you're at your home. For making any single transactions, go to your mobile app, make any single transactions. It is completely online. Speed of transaction is obviously anytime better what we do in your traditional banking or you visit to the branch. Completely access on your own account. So while sitting at your home, while logging to your mobile, you can access all your transactions. You can access all your accounts, what your money doing there. How can you make an investment? How can you make your FDs? Everything can be given on your mobile. It's completely eco-friendly, of course. So this is the small journey of what AU Bank had started with. So we as a group has completed more than 25 years. We started in 1996 with vehicle finance. Later on in 2008, we moved into small business loan, MSME finance. 2011, we started funding to small housing finance. In 2012, we started funding for NBFCs and so on. We started our banking journey in 2017 and our current book size is more than 50,000 crore, which is anytime best in the market into small finance bank category. So this is what we have launched. So customer like you, or maybe, I'm a customer of a bank, what to do with, the banking services. So I can download applications through AU Small Finance, to Play Store, the app called 0101, where I can, make any transaction, where I can use any other services like want to book a cab, want to make book any hotel, maybe movie ticket, or any if I want to reach to my RM, I can download this app. I can do any transactions other than banking transactions. Also, we have several other facilities. So this we have launched the chat Auro, wherein if you don't wish to connect on phone, you can chat, you can do WhatsApp banking, you can do you can call a customer care, you can give us a missed call and we'll be one step away. We have a video banking services as well. So these are a few credit cards which we have launched, and we are the only small finance bank who has their own credit card. So there is no other small finance bank who has launched their own credit card. This you can apply on AU 0101 app, which is available on Play Store. So this is the tabular form, the applications, the facilities what AU Bank service offers you. So we have retail internet banking, we have tablet banking, we have corporate internet banking for customers like business and hospitals like you. We have NEFT RTGS services on one single click. We have mobile banking applications for receiving any funds to POS machine. We have that facility. We have a facility wherein you can receive funds through online, through payment gateway mode. And of course, UPI we also have. So what we provide to hospitals. So we have cash collection, wherein our banking representative will visit the hospital, they will collect the cash and deposit into your account. We have a facility wherein if you don't wish to hand over the cash to the representative, we can install a machine into the hospital. You yourself, your accounts team or finance team can deposit that cash into that machine. Our rep will pick up the machine on the very next day and it will be deposited into your account. So you will have that account, your cash deposit in your home, your hospital. So we have check printing facilities as well, wherein if you're signing thousands of check in a month, so we'll give you a facility. You don't need to sign that check. We'll give you a digital solution where you can just on a single click, you can just print your check with digital sign. And several other facilities we have, like ERP integration. So say for example, my accounts, they find it very difficult to make transaction and after that making a reconciliation of that. So we directly integrate with the software what you use as a hospital. The transaction will be routed directly to the software which you use. It will hit our banking server and the transactions will be executed, and there will be a report which will be sent to the ERP again, and the reconciliation will happen automatically. So there will be no manual intervention. So these all are the various services as a bank we provide for the corporates, for the hospitals like you. For payment solution, we have corporate internet banking and mobile banking. We have online services. You can make your tax payments, your TDS payments, your GST payments through your AU corporate bank. You can make your employee salary payments. We have a facility wherein if you are sitting here in Mumbai and if you wish to make any cash payment to your vendor or maybe your bearer or maybe your family, by sitting here, you can give an instruction to the branch of any other location and this cash will be handed over to the bearer. So we have this cash payout facility as well. Check printing, as I mentioned, that you can print as many as checks sitting into your office with digital signature. In collection solutions, I mentioned that we have doorstep banking facility wherein cash will be picked up or check may be picked up from your office, from your hospital, and it will be deposited into your account. Payment gateway services for any digital collections. Say, for example, if any patient who wish to book any appointment, they can log into your hospital application or maybe the website and they can book an appointment while making the payment through this payment gateway services app. Point of sale, if any customer is visiting and they wish to make any card payment, we have that machine services as well. Check and cash solution, I have already mentioned that it will be picked up from your hospital. Virtual account we have, if you wish, if you don't want to display your account number, we will give you a virtual account number which will be displayed, which will be actual account number will be masked, and you can use this virtual account number and the collections, digitally collections can be done through this virtual account number. Then this, I have already mentioned this API banking, wherein we will directly integrate the service to your ERP system, wherein you don't need to go to banking applications or banking portal. You can directly use your application or maybe the ERP system which you are using and can make banking services. You can download the statement to your application to your ERP system. You can check your bank statement. You can make any transactions and the reconciliation will be taken care by bank. And what do you earn? So the balance which you keep into your account. So we give up to 6.75% of rate of interest into a savings bank account, which is highest in any small finance bank category. And if you see the annualized yield, it is 6.92%. And for senior citizen, it is 7.25 and up to 7.45. It is an annualized yield. What do we give into the savings account? So this was the FD, what we booked. What do you earn on the savings bank account balance? So we give up to 6% or 7% on the higher side for more than 25 lakhs balance, which we keep that to on a monthly mode. So this is the technology award what we have received so far. And we are still working on technology wherein we can do more better for our customers. Thank you so much.
Thank you very much.
Well, friends, I can vouch on this bank because I've been banking with them for quite a long time. And whatever has been said is actually very user-friendly. So do positively visit the stall also for any queries. Thank you.
I would request the chairpersons to felicitate AU Bank. Yeah.
I request all the doctors to collect the lunch coupons from the registration counter and then proceed for lunch. Thank you.
2 minutes before we do that. We'll felicitate the chairpersons also. Yeah. And good afternoon. I would like to take this opportunity to thank everyone. I'm Dr. Maya Prasad, Joint Secretary Web of IMA Mirabhayandar. On behalf of IMA Mirabhayandar, I thank everyone for from the bottom of my heart for making this CME a huge success. With the COVID just reducing and still dilemma of physical CMEs, it was innovative idea of our president, Dr. Rakhi Agarwal, to have hybrid annual CME. I thank Dr. Neeraj Jindal, Secretary IMA Mirabhayandar, and all the office bearers and committee members for sincerely executing this with their hard work day and night. I extend my sincere thanks also to the speakers for a vivid explanation of their topics, and to the chairpersons who took out time for us on a Sunday morning. Thank you, chairpersons. And on last but not the least, the lovely audience who are here present today and were very patient for a smooth running of this session. Thank you, audience. And finally, the most important, IMACON 22 hosted by IMA would not have been possible without the educational grant of the pharma companies. Okay, you want me to take the names? Okay, thank you. Over to Dr. Rakhi.
Thank you so much. I would just, because there was some hitch, we could not play the digital banners. We will see to it that in the evening, digital banners, continuous promotional material is put on. I'll just like to thank sponsors. Of course, first the speakers, Dr. Brijesh Dubey, Dr. Rajesh Koraria, Dr. Ramanan Yadav, Dr. Navneet Desai, Dr. Niranjan Agarwal, Dr. Mahesh Prasad, Dr. Aditya Manke, Dr. Rahul Modi, Dr. Suman Chaurasia, Dr. Harvinder Singh, Dr. Samir Sheikh, Dr. Raghavendra Ramdasi, Dr. Preeti Sharma, and AU Small Finance Bank. And not the least, Quantum High Tech Imaging, AU Small Finance Bank, DigiShield, Brooks Lab, Broadway, Ethicon, Pharmed, Dhanuka Investment, Abbott India Limited, Signatura, In Mode, Pratham, CT MRI, Aryan Hospital, Balaji Orthopedic and General Hospital, Central Hospital, Dr. Pooja Tanwani Hospital,